will be discussing this procedure.
Thank you. This is the patient. Is the patient that performed the hyperopic LASIK. Is not happy of the results. Looking at the topography, I think that he would look up during the surgery, so that the result is the decentrated apex on the cornea. This is the posterior surface that shows us that there is no ectasia, because anterior surface looks like an ectasia. And this is the pachymetry maps, where you can see that the epithelium masquerades really astigmatism that is more irregular than what we can see on the anterior surface. So this is the quality of vision, and we will perform a surgery, and now engineer will explain to you what is the technology, and we hope that this is the post-operative results with a good possibility for the vision, with a good quality of vision, with a good points and function. I go there.
Well, in the meantime, Professor Alessio will prepare and will wear the visor. We'll just tell you how the system works. I mean, first of all, it's a full, complete system where basically the software controls all of the steps. And you may see that you may have several screening centers where the patient delivers to the web the pre-op. The ablation plan is planned into the web, delivered to the laser. The laser will execute the treatment and generate the ablation. The ablation does allow to define the expected post-op, and when the patient will come for the control, we will check if the treatment is exactly as expected. The remote surgery, you will see here, we basically are defining the standards for remote controlled surgery, and you see that this is the tomographer which gets repeatability below 3 micron in order to be sure that the data are fully in compliance with basically the accuracy below 3 micron through basically a dedicated eye tracker. This pupillometer is needed because when we do this kind of surgery, we need to basically balance the refractive zone to the effective needs of the patient, so never 6 millimeter, but as you saw much later. And finally, the ideal shape, we were inspired by Michelangelo, defining basically for each patient the ideal shape to minimize the ablation. So you see that through ray tracing, we will determine this is the case, this is the pre-op, we see the ray tracing come back here. And the ideal shape, as you see, takes care of basically the aberration of the entire optical system. This again is the ablation which will be performed, where we will remove, as you see, only 35 microns of stroma, and of course we will remove contextually the epithelium. And finally, the laser that is going to execute this ablation is a 2 kHz system with the spot size. You will see from here, this is the post-op. And this is the laser which will execute the treatment, which is again a 2 kHz system with a spot size of 350 micron. And Professor Alessio, through this visor, will basically control in the center the 3D vision of the platform, on the right the ablation and the command of the laser, on the left, on the right the software for planning. So, Professor Alessio, if you want to start.
Yeah, we are ready.
As you will see, all of the steps of aligning the system are fully remote controlled, the way that we are totally sure that the data are exactly, basically, as expected. So you will see alignment, control of the pupil, control of the light, and then finally the surgery will start.
Fine. So, as I told you that
as you see now, is performing the alignment. This is fully automated.
8-point marking.
Now alignment is done. Here now we are introducing the dome, is the dome ocular mask. This is to protect the environment during the surgery. Okay. You see all of the steps. The green line is showing the steps that he's doing right now. Pupil control was done. Now he's making iris control to control the features of the eye tracker, the feature of the iris. Now he's making the registration in between the tomographer and the laser. And once registration will be done, basically the surgery will automatically start. He's controlling all of the steps. Now he's performing the last step. Okay. So ready to start the surgery. Now through the joystick he will start the surgery. The surgery, you see, the surgery will take 52 seconds. And you will see now that the laser will start working very gently to just 5 Hz, working in the most delicate region. And then the speed will increase in order to cover in 52 seconds up to 2 kHz the entire area of the treatment. You see, the surgery started. You see the laser spot working on the shape of the cornea. The bar on the left shows the progressing of the time. And you see that it's replicating the shape on the cornea. And then surgery is done. So this is basically to allow the surgeon, wherever he is, to control by remote surgery, to allow wherever the patient lives, the same chance of success, no matter where basically the treatment is performed. Thank you.
Zainab, will you do my PRK with you in Houston and I'll be in Cincinnati?
I was just telling Ed, the new generation of residents who are all about work-life balance are going to love this kind of surgery. They don't even have to go to work anymore, right? I think that's all we need now.
Any questions or comments from the audience? This session hopefully will be more interactive and we can take any comments from the audience. Okay, well thank you. Thank you. Thank you. So are we ready to move to the live surgery, DMAC?
Is it centered?
Hello? Can you hear me?
Yes, yes.
Yes, we can hear you.
Okay, so we are in theater with Dr. Bazak that has started performing the first few steps of the DMAC surgery. So do you have the slides of the case? Okay, perfect. So I shortly present you the case that he's operating on this afternoon. So this is a case of a patient with Fuchs endothelial dystrophy. It's a 74-year-old male that had cataract surgery in the left eye 12 years ago. As you can see in the left eye, he has corneal edema, corneal gut, and it's pseudophakic. Visual acuity in the left eye is 20/100 with a good intraocular pressure. You can see that there is the edema in the cornea, and the pachymetry measured a corneal thickness of 681 micron with an anterior chamber depth of 2.83 millimeter. And we also measured the parameters of the pupil before and after dilation before surgery, but we will get back to this maybe later in a bit more details, so that now we can go directly to the surgery. As you can see, he has already performed
the DM Rexis also.
So he has started from a superior approach. As you can see, we have already arrived at the stage of the decimetrexis. He has started with a mark on the outer corneal surface of 8.5 millimeter diameter, performed 2 side port and the main incision, a post-limbal main incision. Did a little bit of cautery to avoid bleeding during the following procedure. He has put a bit of trypan glue in the AC to visualize the decimat membrane. And then under Hilon GB, he performed the scoring of the decimat membrane. Hilon Pro. Sorry, he used Hilon Pro. And he performed the decimetrexis and removed the decimat membrane. Now he is carefully washing the viscoelastic from the anterior chamber, because in the next phases of the surgery, of course, we don't want to have any residual viscoelastic inside the anterior chamber. So there is this phase of careful washing, also repeat washing, to be sure that no residual will be left in the anterior chamber. So he's using this superior approach we discussed before, the type of incision. This patient has a white of about 11 millimeter. So the main incision was slightly post-limbal to allow for main space compared to a direct corneal incision for the following maneuvers. Now you can see that he has left an air bubble inside the eye.
See, the idea of putting air after, I always dissect the recipient first. The idea is to put the air after washing the Hilon. Then you need to see what is the edges of DM, what you have done Rexis. So you can see jolly well the edge. These marks are actually 8.5 millimeter mark. These are template marks, so my DM Rexis size is 8.5 or little more. So you can see the edges of the DM. This will help to center the graft. So air also helps to, when there is more corneal edema, it also decompresses a little bit of fluid from the corneal stroma, so you see more during manipulation of donor tissue. Now you carry on. So I'll prepare the donor now.
Okay, so now he will start the preparation of the donor tissue. So the donor tissue that he will be using it comes from the Venice Eye Bank. The donor is a 71-year-old female, and we do have 2,600 cells per square millimeter, and the morphology of the cells are of a good morphology. So we have a good tissue today. So now they are taking the tissue out from the medium.
Or you can just... That is easier.
Okay, so in this case, they are getting the cornea. So the cornea has been pre-peeled from the Venice Eye Bank. It has also been pre-stamped. However, I discussed this with Dr. Bezek before, and he liked to make sure that the stamp on the cornea that he's going to transplant, so the descemet membrane and endothelium, is a good stamp. So he will remark the cornea. He uses an S mark.
Already, S mark is done already, I think.
Okay, now we are checking because we might be fine with the pre-done mark. Now we'll see if he prefers to do that himself or it's already well visible on the cornea. We have an F mark. I think that now you can see the tissue.
No, F is there, not S.
Correct. There is an F mark.
So F mark is there. Give me a friend.
So he is highlighting the center of the cornea before punching the cornea at the desired size.
I want to see the edges. Give me a syringe of water. Okay.
So you can see that there is a bit of the tissue is a pre-stripped tissue. The F mark is quite well visible.
Just I want to check where is the hinge. That's why I have floated the tissue. It is very difficult sometimes to understand the hinge.
So he's looking for...
I have now checked the hinge. So you need to check. So 8 millimeter. Give me 8 millimeter punch.
Okay, so now we have checked the position of the hinge because the tissue was pre-stripped. Now that it has been identified, he has decided the size of the DMAC, so the donor tissue will be punched at an 8 millimeter size. So we are now opening the punch for preparing the instrument. I don't know if you have any question from the audience.
I am defining the age of the graft because that is very important for central or little bit eccentric is the foot switch.
So he wants to have a very well-centered punch, so he's highlighting all the border.
So 8.5 millimeter, 8 millimeter, my punch. 8 already I separated 8.
We confirm the 8 millimeter punch. So we discussed before about whether Dr. Bazak usually do a peripheral iridotomy or iridectomy or not during the DMAC surgery. As you can see, he has not performed it. We have checked before the surgery in the patient, like during a normal visit, the dilation of the pupil, so the diameter of the pupil during dilation. This was more than 6 millimeter, which was the size that Dr. Bazak normally chooses for deciding whether a PI is needed or not for a patient receiving a DMAC. When the pupil size after dilation is above 6 millimeter, he doesn't perform a PI. Otherwise, he do that intraoperatively, only in cases in which we do have a small pupil after dilation. Now you can see that the tissue has been punched at the desired size.
Give me my first one. No.
If you have any questions or comments.
Intentionally, I have done eccentric definition. This is my area of interest. Last 7-8 years I am studying this. And you see that there is a gap between, I have not done a central definition. So now we know that peripheral endothelium has more cells than the center. So I am trying to give the more cells to the patient. So you see this gap and this gap. This is hardly 1 millimeter, this might be around 4 millimeter. So that is interesting to see so recently we have in cornea journal our paper is accepted 5 years result. So these patients are doing good. Overall we are giving more than 250 cells. So now I'll put trypan blue. This is for maybe 1 minute or less. So keep it like this. So I'll come back here. No, I'll come back at the end. So if you have any question, you may ask me. So I need this too.
As you can see in this case, the epithelium was left inside, was left on the top of the cornea. In some cases, we discussed that when there is poor visibility and the patient has an advanced pseudophakic bolus keratopathy, he might decide to perform epithelium removal before the following maneuvers.
Maybe less than a
Also,
minute.
you have seen briefly in the first phases because Dr. Bazak was very quick in the first metrexis that the diseased endothelium was initially stained with trypan blue in the recipient. He does not perform this procedure every time. However, to enhance the visibility of the diseased endothelium, he sometimes uses the trypan blue just to highlight it before using that heel on before performing the metrexis.
Give it to me.
So now we are staining the graft. We want to have a good staining so that it will keep highlighting the descemet membrane and the endothelium during the following maneuvers in the anterior chamber.
So let's shift this tissue over a petri dish. So again,
You can
DSS to cc syringe.
you can see the graft
So you
has been
also
transferred
give-
into PSS. Now he's moving the graft to see its behavior
Very
and
good.
to look for a good folding before loading it. For the injection, he will use a homemade injector. He prepared the injector himself using an IOL cartridge from the 140 sensor multi-piece J&J, and add also a rubber part to the injector that he makes from the tubing system of the EV injection of the patient, and then he do the ETO sterilization. So every day he prepares the DMAC injector himself. And we will use this type of injector for the following step of the surgery.
So I need that one. Very, very gentle. Do not touch here. Yeah.
Now we go back to the recipient eye. He needs to remove this air
Put-
bubble
put-
from
put
the
VSS,
anterior
yes.
chamber.
Yes.
So it's using now
No, not so
VSS
fast. Slowly.
in the anterior chamber. He is asking to have a slow flux of
Okay, done.
VSS,
So
just
I
for
need
being gentle in
now
the eye.
this one. I need. Okay, no, not this one. This one. This another 2 cc syringe. You feed.
The DMAC graft has been
This is-
loaded
this should be ready,
into
and that should
the
be ready.
injector
You remove this thing.
that I
All
told you
are
about.
not required. All are not required. So, okay. Yeah, so ready with this syringe. So I need 2 or 3 times this one. Oh,
So
I need the
we are.
watch,
He's asking to have prepared different syringes with
this is very
VSS
important step
because
to
in the
protect
following
the graft
maneuvers
as well as to
he
lift
might
the-
need to require more VSS. So he wants to have the following syringes ready just in case he
So I
finishes
can-
the VSS in one and for the graft folding.
little bit.
There is the need of some more VSS.
Now is it perfectly focused? And perfectly centered also? So this is the last stage and the final stage. You just wet the cornea.
So we are now at the toughest moment of the surgery, which is the injection of the graft and the unfolding of the graft in the anterior chamber. As you can see, he is entering the anterior chamber with injection.
What's the diameter of the wound and the injector?
So the wound is 3 millimeters.
3 millimeter.
And the injection?
Injector, it is same.
It's the same
It is
size.
2.8 millimeter. This is so that's we can go easily.
2.8 millimeter the injector and 3 millimeter the wound. And the patient had preoperatively an anterior chamber depth, I recall you, of 2.83 millimeter. Now the graft is well stained. It's in the anterior chamber. And now he is performing the tapping maneuvers. Trying to keep the eye still, working with a shallow anterior chamber. And as you can see with this tapping, he's gently unfolding we should be already in the correct orientation of the graft. It's very important when injecting the graft that he paid attention on the position of the graft in the injection.
Wet the cornea.
We are well centered now with tapping maneuvers. Hopefully we'll manage to unfold the graft. Injected a bit of VSS to help the unfolding.
No, it is reverse.
Now I think it has
It is
become reversed.
reverse. Now it is fine.
So now he has, as you can see with these maneuvers, he noticed that the graft was reversed and injecting VSS from the side port, he just washed the anterior chamber and helped the graft to reverse completely and trying to get back to the correct positioning of the graft. You he's also using some pressure on the center of the cornea to try to keep the graft in position while at the same time tapping to help the unfolding. You can see the mark on the outside of the cornea that were made at the beginning of the surgery. The marks are at an 8.5 millimeter size, while the graft that has been transplanted is 8 millimeter in diameter. More than halfway on the unfolding, now the last bit. Still well stained.
This is a mark, so I think I'm all right. So you do have ISOCG.
You can see, can you see from the screen the F mark? We can see it from the OR. It's in the superior part.
Yes, here it is.
At the level of the main wound, you can see that
here you can see actually.
He's now highlighting the F mark. You can see that it's the F mark is in the correct position.
So I'll use the air.
The graft is well centered.
Completely centered. So IOCT is not there, no? Oh.
Now he's preparing to inject air. For the air injection,
I'm sure, I'm more or less sure.
He's using a 1 ml syringe just to control slowly the influx of air in the anterior chamber. So he's now going behind the graft.
Oh, that is the main problem. Sometimes it happens, the graft actually shifts during the injection, so I have to take out the...
Okay, he has injected the first bubble of air, and he has noticed that the graft has slightly shifted. So now he is doing a few more maneuvers to center the graft back into position. Sometimes it happens.
No, shifted little.
So with very careful maneuvers, he is recentering the graft, looking at the outside mark and the well-marked graft in the eye.
Little eccentric, still little eccentric.
Very precise surgery, so he wants to have a real good centration.
I think we should leave here. More or less centered, not absolutely centered, but...
Quite happy with the centration, so we go back to the air.
It's air?
Now
Not
it's air.
gas.
No, not gas.
So no, he is not using gas, he is using air.
So,
He uses... So very good. You can see that the graft is perfectly in position. So he uses air and he fills the anterior chamber, leaving this small brim of VSS around. Generally, he doesn't use gas. However, there are a few patients in which he prefers, in which Dr. Bezak prefers using. Okay, so he's highlighting you the F mark, as you can see. As you can see, it's in the correct orientation. Very nice way of showing the F mark. Very smart. And he normally uses air. However, there are a few patients in which he might decide to use gas, and those are generally patients with either vitrectomized eyes or eyes with an anterior chamber IOL, scleral fixated IOL, or also in cases in which Dr. Bazak expects the patient not to position well after surgery. But otherwise, his first choice for DMAC, for routine DMAC surgery is air. As you can see, he hasn't put any suture. In uncomplicated cases, he does not use suture, and now he has done a bit of cautery on the conjunctiva.
Just put one drop of tropicacil, that combo drop and one drop
so
of
now
atropine.
He's using drops of atropine
And mixture
and the mixture of tropicamide and phenylephrine.
So you just put one drop right now. Yes. Now for dilatation.
Okay, now we are getting atropine and the mixture of phenylephrine and tropicamide for dilating the pupil. This patient we will
Because I have not done PI. This is PI less.
So he
One
has
drop,
done
one
the
drop.
PI, so now we need to dilate the pupil of the patient
So I
to prevent
have,
pupillary block with the air. The patient will be immediately positioned to bed to keep the position, and he will recheck the patient at about 1 hour after surgery.
And cataract drop.
At 1 hour after surgery, in this series, maybe 1 out of 10 patients, there might be the need, correct, of part the patient
If it's
slightly,
required,
if it's required. In this series, is about 1 out of 10 patients might require removal of a bit of air 1-2 hours after surgery. He checked whether the air bubble at 1 hour is above the pupil or not. If it's above the pupil, it's fine. Otherwise, he will barb it a little bit.
So
Do you have any questions for Dr. Max?
Is there a reason why you prefer air over gas? Is there a reason why you prefer air over gas?
So, Dr. Bazak, is there a reason why you prefer
Yes, sir.
air?
Question, sir.
Is there a reason when you prefer air or gas?
No, I never use gas. I always use air. And gas only in difficult cases, not always. So maybe out of 100, maybe 2-3 cases I use 1 drop each. And this is atropine.
So, Dr. Basak, we want to thank you for this excellent surgery. We're going to move on to the panel discussion. We
Sure,
appreciate
sir,
you being
sure.
part of the program. Thank you.
Thank you, sir.
So maybe before we get on, let's talk a little bit about what we like about DMAC and what we don't like about DMAC.
Well, I guess we all like DMAC, particularly in these cases. Results at 5 years or 10 years are excellent in terms of graft survival, more than 90%. And so in this case, it works extremely well. And we can say that it's the main indication, it's a gold standard nowadays for Fuchs endothelial dystrophy is certainly a DMAC. And, but of course, there might be different opinions for other types of endothelial decompensations where things may be more difficult to handle.
Well, and I think the other aspect, even in great surgeons' hands, sometimes opening up the graft can become mechanically difficult. Other times it can go pretty quickly. The other aspect is when we look at our data, even though you look at a lot of the outcomes and published outcomes, we say that, for example, graft detachment's less than 10%. But in reality, it can be higher, and it goes back to the point of, I use gas for all our cases instead of air because it definitely decreased our rebubble rate. But it still happens. And then also reverse pupillary blocks. So I would say, I agree, the outcomes are amazing. The vision is excellent, but there are still potential complications, especially in that first week post-operatively.
So excellent video, and thank you so much, Dr. Basak. I do agree with all those points, and DMEC has really changed the way we treat patients with endothelial dystrophy. It's more anatomically correct, and I would say in the last 10 years we've seen this real revolution and refinement of the skills, so much so that our surgical fellows and cornea fellowships have become so, they come to be at ease with the DMEC surgery so much so that it's easier for them to do than D-sex surgery. So I think it's become more and more evolved and more streamlined over the years.
You know, I think as good as it is, we still have significant issues. You know, patient compliance with laying on their back, it's especially elderly patients. And most surgeons now move beyond 1 day to 2 to 3 to 4 days because the graft detachment rate still is 10 to 15% in most surgeons' hands. And then once you have that detachment, you have to rebubble it, changes kind of the course. So that, and then we talk about complex eyes, you know, eyes with tube shuts, eyes with deep anterior chambers, aphakic eyes that are very complicated. I don't think they do nearly as well. And then even though rejection is very, very low, we still have rejection in these eyes. Once you have a rejection reaction, you know, that increases the risk of rejection for the next graft. So now we're going to move on to what we're thinking about in the next generation of endothelial replacement, and Luigi Fontana is going to talk about EndoArt.
What I brought is a novel technique for both combined penetrating keratoplasty and endothelial replacement. It's called PK Smart, which stands for sutureless membrane artificial endothelial replacement. This is what we aim to do, is basically creating a hybrid cornea where there is a penetrating keratoplasty with an embedded artificial endothelium, okay, which is the EndoArt. The rationale for this is to create a stromal replacement where the patient needs to be operated for stromal opacity, and also to create a caveat for endothelial dysfunction through the implantation of an endothelial membrane, which is in this case is EndoArt. The advantages compared to the standard technique of implantation of an EndoArt is the fact that we do not need transcorneal sutures. There is no air or gas injection, no need for posturing the patient, and of course this is a technique that has to be applied in high-risk patients. This is how we do it manually, okay, which is rather straightforward. Basically, we place a donor donor graft on an artificial anterior chamber upside down with the endothelium facing up. Then we take a donor punch, we create a groove of about 5 millimeters in diameter. We sculpture a pocket with a disc knife, and then we implant the EndoArt inside this pocket. Then, of course, we reverse the cornea, we place it on the punch, and then we can implant it on the recipient cornea. And this is our first 4 cases that we operated on. They were all patients who had a failed PK or multiple failed PKs and endothelial also decompensation. You see in the top left that there is a patient with detached DSEC with a captured IOL, and the bottom left is a patient who has retained silicone oil after several VR procedures, and the other ones are patients who had multiple PK performed for keratoconus. They all failed, and there is a stromal opacity. Now, these are some of the results in the early 3 cases that we operated on, and this is how appears the cornea at 6 months after surgery. You see that the central part of the cornea is clear, the peripheral part of the cornea, of course, is cloudy, but this is the effect of the artificial endothelial replacement with the EndoArt that, of course, keeps the central cornea clear, which is what we want. In synthesis, this procedure addresses both stromal disease and endothelial failure at the same time, specifically designed for high-risk cases with no use of no sutures, no air, no gas, no postoperative posturing. There is an edge-to-edge biological interface, so basically there is no exposed artificial element to the surface of the eye, which is one advantage for a keratoprosthesis. And of course, indeed, we can use corneas for this procedure that may be not suitable for penetrating keratoplasty, but for instance, may be suitable for DLK. Thank you for your attention.
Great presentation, and you talked about the benefits over just doing endo art, but are the benefits over just doing full thickness transplant, PK for example, is because of the endothelial cells and risk of rejection potentially and utilization of tissue that isn't great? Is that why you would do this over just, PK?
Exactly. I mean, these are patients who already failed multiple PKs and EKs, and of course we know that the chances of a new PK or EK of surviving is very limited.
I think it's brilliant. It's almost like you made your own K-Pro, like a keratoprosthesis in a way.
I haven't mentioned that, but you can call it that way. I call it the hybrid cornea, but everything is hybrid nowadays.
It's very ingenious because you've eliminated one of the biggest problems with endo art is that it's dislocation and multiple, repositioning. But one of the other complaints I've heard of endo art is the interface haze anterior to the device. Are you seeing any interface haze? And why do you think the vision at best is 2150 and not better?
Well, difficult to say, difficult to answer. Of course, these were extreme cases that we operated on. One had retained silicone oil and it couldn't be removed. Of course, we know that in these cases, chances of getting better vision is almost impossible. And there are multiple comorbidities in this patient, glaucoma, for instance, in most of the cases that we operated on. So chances of judging what is the visual potential of this procedure is at the moment fairly limited to me, but certainly our task is actually to try to improve the vision to a significant point, but most importantly, to try to preserve and maintain this achievement for a prolonged period of time, potentially for years.
Great. We look forward to hearing some more data on this unique approach to patients with high-risk transplants.
Thank you.
The next presentation will be by Dr. Koo, talking about MSL's approach to injection cell therapy.
Thank you so much for the introduction. Thank you for having me today. Okay, so I think the promise of endothelial cell therapy is that we are able to treat patients with endothelial dystrophy and dysfunction in a different way. The real promise of this therapy is that we may be able to address the corneal dermal tissue issue, short-term tissue around the world. And also the advantage of this therapy is that we can circumvent the need for an operating room potentially, because this is something we can do either at the slit lamp in the office, or this is a patient of mine that I injected in our LASIK suite. So this is something accessible to all and hopefully decrease the barrier to care for a lot of our patients. And so the patient, after getting the injection, they will wear an external eye patch like they do for after cataract surgery, except the eye patch is magnetized. So this magnetic therapy essentially allows the cells to migrate towards the magnetic field. And you can see the plaque of cells really congregated in the left of the picture. That's a patient who received 1 million cells. And the magnetic patch offers this magnetic field which follows this magnetophoretic sinusoidal therapy. So essentially those cells really congregate in the center versus the periphery. And you can see on the right, this is a patient who received 150,000 cells. Less of this plaque effect, but essentially the plaque represent layers and layers of cells stacked upon each other because the force of the magnetic field is so strong. And so this is a video that really demonstrates the nature of that magnetic field. So these are cells that are essentially tied or tagged to magnetic nanoparticles. And with an external magnet, you can see these cells really migrating towards that magnet, as you can see on the left. And this is pretty impressive. This is less than a few seconds. It gets even better. So you can see those cells really migrating back towards that magnet. and this goes to show how strong that magnetic field is. So as far as visual acuity gains, we saw an improvement in all three groups of patients who received 150,000 cells, 500,000 cells, and 1 million cells. The line in turquoise denotes patient with 150,000, and the dark blue will be 500,000, and 1 million denoted by the maroon colored line. So we saw this dip in vision at 1 week with 500,000 and 1 million, but we did not see this with 150,000. And that makes sense because we're not getting that giant plaque of cells in 150,000 cells, because those cells, when they're really stacked upon each other, they're still needing to migrate and become a monolayer. So we are seeing this dip in vision when you inject too many cells. Realistically, there's really no room to house 1 million cells in the endothelial mosaic. The endothelial mosaic can probably house 250,000 to 300,000. So when you inject 1 million cells, you're going to have an excess of cells, as you saw in the photo. Another graphic that shows us that we saw this mean change visual acuity with 150,000 cells, more so than 500,000 versus 1 million. And same for lines of vision gain, as well as percent of patients who achieved greater than 20/40 vision. The other word that's been tagged to endothelial cell therapy is the word regeneration or rejuvenation. And this is because we're introducing a healthy, homogeneous line of cells to the antechamber. And so we had actually 4 patients who had received retroillumination photos who were treated with this cell therapy. We collected images at baseline, 3 months, 6 months after injection, and we had a grid that allowed us to count the number of guttae in each section. This is a method that was validated by Wilmer John Gotch's group many years ago, and so we had 2 independent masked investigators who manually quantified each guttae. So this is a really time-consuming method that really helped us elucidate what we are seeing. There's a patient at baseline, and after cell injection, we saw this decrease in guttae with the same retroillumination photo technique. And another patient of mine who received this therapy at baseline, you can see and all these guttae, and at 6 months, we saw this blunting of this effect. And you can use that non-ruptured bullae as a landmark. You can see a definite reduction in guttae over time. So we quantified this decrease in guttae over time, and what was incredible was that we're seeing this concentrated effect in the center versus the periphery. So the x-axis denotes the center to the periphery, so A will be the center, G is the periphery. Y-axis denotes percent of guttae decrease from baseline, and we saw this decrease in effects towards the periphery, which makes sense because the magnetic force is so strong in the middle. You're seeing this marked effect in the middle of the cornea versus the periphery. And what was really exciting to see was at 3 months, we're seeing this effect denoted by the gray bars, but we see this sustained effect, meaning we see continued improvement over time up to 6 months in these patients. So that was really exciting in our study. So we're gearing towards the next phase of our clinical trial, and we look forward to reporting our data. Thank you so much.
Dr. Almodo will be talking on injection cell therapy from the Orient Biotech clinical trials.
Yep. Thank you again for being here. I think this whole session was started amazingly well with the great surgical technique of DMEK. And the reason we're talking about corneal endothelial cell therapy is that we have a ways to go to improve where we are now currently. There's a huge prevalence of more than 15 million people that need endothelial keratoplasty, and unfortunately, only 70,000 receive it for multiple reasons. For example, inability to get tissue. 1 in 70 patients, sometimes we can't even get donor tissue. But really, the complexity of the procedure itself, I'm going to actually talk about this first. And we hit on it with not just the procedure itself being difficult, but really for the patients. Patients delay doing surgery because they don't want to lie flat on their back. And then also the potential complications we talked about, and even in the hands of the best surgeons. And so what's really exciting about the Orion and the endothelial cell injection therapy is, please look at the video while we talk about this. The number one most exciting thing is the fact that one donor cornea can treat 1,000 patients. So that creates enough doses for 1,000 patients. That in itself is huge. Secondly, is theoretically, we're injecting less antigenic load, right? You're injecting just the endothelial cells, not the Descemet's membrane. And with that, we see how small of a percentage you get rejection with DMEK. But now, this is even a theoretically less risk. And we'll talk a little bit about the numbers and that we haven't seen one. So what you do in this procedure is you go in with a 1.2 millimeter incision with a silicone tip irrigator to polish the endothelium. So you're not removing endothelial cells, but you are polishing it and you're mechanically blunting the guttae that are there. The reason we put the Trypan blue, you won't need to do it in the procedure itself, is just to make sure that you polish correctly in the zone between 6 to 8 millimeters. And then you inject the endothelial cells into the anterior chamber. And then you're done with that procedure. And you know what's really, really exciting is the accessibility and the straightforwardness of the procedure. The patient is face down for 3 hours at the time of surgery, but then there is no limitation on what they need to do after surgery. So endothelial cell therapy is exciting. There are 4 different companies. We heard from MSL, from Dr. Koo with their great presentation. OcuCell and Linear are still preclinical, so we don't know much about, there's not much data, but also exciting. Orion is the company that has been doing multiple studies. It's already approved in Japan, commercially available, and many patients are currently treated in Japan. Phase 1, Phase 2 CLARA trial was done last year with excellent outcome, and we're currently enrolling in the Phase 3 study. And again, the data has been really, really excellent. But before that, in the United States, there has been more than 250 patients treated. It started, of course, with Dr. Kinoshita in Japan, where we have data in these patients for over 10 years. It was also performed both the dose ranging studies and then the Rho kinase inhibitor dosage studies that was done in 2 different studies in El Salvador. And then we talked about the CLARA trial that was done in the US, Phase 1, Phase 2. And then in addition is this cryopreserved endothelial cells. So imagine having this on the shelf with your endothelial cells instead of just waiting for it to come to you. And we went to El Salvador and performed this procedure on those patients with the cryopreserved. This is really the money slide, looking at more than 10 years therapeutic outcome. You know, when you inject a DMEK, the number of cells, because of the mechanical pushing on the cornea and just what you do with the graft, the cells do decrease pretty significantly at that initial time and then decrease over time. What we're seeing, even our 1 year looking at this data, is really the lasting endothelial cells that occur there. Number 2, when we talk about the guttae, if you look at, again, the endothelial cells, you can see blunting of that guttae that improves over time. So you have that initial mechanical improvement from the polishing, but again, with the regeneration of the monolayer, you see that significant improvement. Long-term improvement in best-corrected visual acuity, both in 3-line gain, decrease in corneal thickness, in all kinds of patients. In El Salvador, very complex PBK patients, and then mostly Fuchs patients in the United States in the study. The other aspect is really the safety profile. No issues in terms of average, no increase in IOP over time. These are endothelial cells, so they're not stem cells. So there isn't any of those other issues that people worry about in terms of, and then no ocular serious adverse events that occurred. Thank you.
Just comment on polishing, whether to polish or not to polish, and Orion has looked at this issue and done cell injection therapy with no polishing. And number one, the cells don't adhere as well if you leave diseased endothelium. But more importantly, one of our investigators, Dr. Martin De La Presa, just finished a trial where he did polishing and no polishing on DMEK eyes, and then stripped the DMEK and then sent it to pathology. So what we find is a significant amount of the posterior decimates comes off with guttata. So the polishing technique removes a significant amount of guttata, and as Dr. Koo has shown, over time, as the new endothelium becomes healthy, the remaining guttata go away. So one of the concerns I think, DMEC surgeons had was, well, if you're treating mostly Fuchs and you're leaving all that guttata, will you have a poor quality of vision? And it's really happy to report that guttata basically over time disappear because of the polishing, because of the healthy endothelium. So just let's talk about what we think will be the acceptance. I think it's pretty obvious if you're in an area of the world that has no corneas, you're going to take cryo corneas, and it's going to be a game changer for hundreds of thousands of patients. But what about the high volume DMEC surgeon? What do you think they're going to do with this technology?
I can start us off. If I cannot do another DMEC surgery for the rest of my life, I would be ecstatic and happy. And I do a ton of DMEC. And I think part of it is, of course, once you get comfortable with doing a Fuchs patient, pseudophakic, things go well with surgery. But what about the DMECs we do under penetrating keratoplasty? What about all the tube shunts? What about all of those patients that it is a pretty difficult surgery? To me, I see endothelial cell transplantation, really that therapy taken away, even us needing to do DMEC personally.
I agree. I think it lowers the learning curve and really the access to patients. The other thing is we may be able to catch and address patients at an earlier stage. I think there is a threshold where surgeons and patients wait till they go through DMEC surgery because of intraoperative, postoperative risk and so forth. But we can potentially reach those patients who are maybe 2025, getting some early symptoms from Fuchs, maybe even 2020 minus. I think we should be able to reach more people, more Fuchs patients with this therapy.
Do either of you have any concerns about the trials and what's next and what should be the big watch out for cell therapy as we look forward to the completion of the trials?
As far as what we're going to see,
any concerns? This might. I mean, the data looks incredible from both companies. The patient acceptance is unbelievable. In the Orient trials, several patients had. You can talk about your patients.
I can talk about my patient actually. So I had a patient that had DMEC in one eye, and did not do the other eye, and that's because they had to rebubble that eye. It took forever to heal, and just the whole process. And they're a very anxious patient. So we actually enrolled them in the trial for the endothelial cell injection therapy. And every single time I see the patient, they tell me, I just wish we had this before I did the DMEC. So, I've had a couple of those patients in the trial, and they all preferred the eye that did not have DMEC. And again, our outcomes with DMEC are amazing. I don't want to take that away, but we looked at studies, for example, the higher order aberration profile after DMEC surgery, because I do a ton of patients, for example, with LAL, and it's still higher than the normal patient because you still have, even though it's not like DSEC where you have sort of stroma on stroma, but you're still changing that posterior curvature. I think that's another benefit from a refractive outcomes when we do our cataract surgery in these patients with endothelial cells instead of combined with DMEC.
I think also what needs to be elucidated is how many cells, how frequently, how often over a lifetime, and so forth. These are all questions that need to be elucidated. I think you mentioned a really good point about the guttae. Perhaps polishing is playing a role. Perhaps just the addition, even without polishing, just the addition of healthy cell line is doing something to those endothelial cells. So I think these are all questions that can be elucidated with the future of these trials.
Any questions from the audience before we move to the next? Yes.
So, my question is, what is the really expected physiopathology for the guttas to improve? Because really, it's hard to believe that endothelium will just eat the good eye. Yesterday was a very interesting free paper from the Cruz group where they did the polishing and then they did the they filled with endothelium, the gutta is still there. So how is it possible that the gutta just fades with only endothelium?
Yes, so I think the distinction here is important. We're not claiming that we are proving the exact molecular mechanism by which the gutta is being altered. What we're showing is that after the intracameral injection of magnetic cell therapy without polishing or surgical manipulation, we're seeing progressive and quantifiable reduction in clinically visible central guttae. So we saw the effect present at 3 months, and then even greater at 6 months. So, and more pronounced in the central paracentral area where the cells are targeted. So that spatial and temporal pattern is difficult to dismiss as simple noise. I agree that ex vivo work was useful, but it's still ex vivo. It cannot exclude in vivo remodeling. What it can show is that cells may cover or populate Goutte surface, which they showed, but without protein analysis, without RNA analysis, extracellular matrix markers, or structured long-term, months-long imaging over many months, it cannot conclude that Goutte matrix is biologically unchanged. So I do not think covering is a trivial explanation. In Fuchs dystrophy, the pathology is interaction between the abnormal ECM and endothelial cell stress. So if cells repopulate and reorganize that surface, that is disease modification at tissue level. And here's an analogy that we see all the time. If epithelial cells resurface an irregular basement membrane after injury, and the clinical opacity improves, we do not dismiss that as just covering. There is clinical tissue architecture change that's going on. So I would view these studies as being complementary as opposed to being contradictory. In fact, they showed that even when residual Goutte endothelial cells were present after vigorous polishing, the new cells were still accepted. So we know that there is a complex cell-to-cell and cell matrix interaction, and we even saw food processes that the new cells were growing in that study.
We're also doing contact, looking at the endothelial cells. And again, I've done these procedures. There is a mechanical blunting of the Goutte, surgically speaking, even when you look at the contact, looking at the endothelial cells, looking at your slit lamp. And we think the other aspect is laying down the extracellular matrix with newer cells, and again, sort of filling in the gaps with Decimase membrane. Over time, you should look at actually Kaneshita's paper that looked at these endothelial cells even at 10-year mark, and you can see the difference. So not all of them go away in that 10-year study, but there is a significant reduction, and that's what we can say right now.
And why not doing desmaturexis and putting the cells?
So that back to his point. I mean, the key is right now getting approval, and then we can do so many different things, right? Maybe some patients, in the future, we believe that patients who have really bad Goutte that is centrally located, maybe they will do better. But some of the patients that they did in El Salvador, where they did injection of endothelial cells after a desmetorexis, the cells didn't attach as well. So there's still so much, again, we're just doing the FDA trial following the exact protocol. So there's so much that we don't know, but that is one thing I'm very excited to think about. Like maybe some patients you only polish, maybe other patients you do desmetorexis. So again, we still don't know.
I think injected cells do like to stick to basement membrane. So before we did the randomized mass escalation, we did have patients who did get stripping, but the fact is endothelial cells do like to stick to basement membrane, especially when they're just being injected. The different model is Fuchs dystrophy and Decimase stripping only. Those cells are not freely injected cells. They're migrating along a pattern already. So it's a different story than freely injected cells. So I do believe we still need some sort of basement membrane for those cells to stick.
Yeah, remember Dr. Cruz's work is in vitro, and it really isn't what we see clinically. And I would, Dr. De La Presse's paper was recently submitted. He actually shows with histopathology, you remove the posterior third of Decimase and removing Guttata, but leaving the rest of Decimase. Number one, that surgically is much easier. Polishing literally takes us 3 to 4 passes of a silicone sleeve on the posterior cornea. We're not stripping Decimase, which can be problematic, especially if you have poor vision through an eye with a lot of edema. Secondly, over time, we've seen patients at 6 months and 12 months, we see the Guttata disappear. In fact, you can see the edge of the polishing zone, which has been 8 millimeters or 6 millimeters. Peripheral to that, there's some fake Guttata. Central to that, no Guttata. So I think the Guttata question will be answered, and I'd rather not strip than strip if I can get away with it. One last question, we have to move to the next.
Yeah, question to Dr. Ko. Thank you for the presentation. Endothelial cells do not divide, so the concentration of nanoparticles will not decrease with time compared to other cell tags, do you expect any issues with iron deposition in the cornea?
So these are, safe biological nanoparticles for injection. We're not the first field to use nanoparticles. We've actually seen our oncology colleagues use this for chemotherapy targeting drugs. So we know they are excreted by the body, and it's perfectly safe to undergo MRIs and so forth.
Yeah, but in those cells they divide. That's what I thought.
Oh, no. They're tagged after the cell line's been expanded. So, is that what you're asking? Or?
I'll come to you later.
Yeah.
Well, thank you both for great presentation discussion. We're moving to the surface of the eye, and we're going to have Dr. Chuck talk about DMAC. But first of all, we didn't have an opportunity. He did such a great job in his constitutional autograph, but we didn't go back to Albert, and thank you for that beautiful surgery. So a round of applause for Albert for that. And if Dr. Jalilian, Basu, and Elisami can come up.
Thank you for the invitation to speak here. This is the brain keratoplasty with right-handed allograft. I've consulted for Bright Star Therapeutics, otherwise other financial disclosures. It's exciting to introduce another procedure that we could use for ocular surface here. What is DMAC? It's decellularized distal membrane, and you're using this as a scaffold for epithelialization. And this can be a newer approach to helping heal the corneal surface and possibly support native limbal epithelial stem cells. And we'll sort of talk a little bit about that science. It's also known as right-handed anterior keratoplasty, or BMAC, currently it's available via Bright Star Therapeutics and their distribution partner iBanks. So how does it work? So we're relying on a distal membrane and how it expresses limbal basement membrane proteins on its anterior aspect. So the spark BM40 and pituitary has some similarities to the limbus, but not really the central cornea. And this can act as a substrate to anchor new epithelial cells and have its healing properties. And it also can protect over the underlying stroma as well. Potential ideal candidates for DMAC are those with partial limbal stem cell deficiency, with or without epithelial defects. This doesn't provide stem cells, and so that's why it's probably more ideal and partial. And then other epitheliopathies, such as those with non-healing corneal epithelial defects, neurotrophic keratopathies, and other etiologies that result in that, such as herpes simplex and zoster, post-operative or post-infectious, medicamentosa toxicity, and contact lens overuse, and also refractory recurrent corneal erosions can be a potential etiology. The procedure is shown briefly here in these images, and we'll go through a video as well. So you have your prepared pre-strip tissue, and you do a superficial keratectomy. You then pre-punch the tissue, and you place this on the dry surface. You can wet the edges and then lift the anterior cap. You're leaving the distal membrane behind. You smooth that out, and you place tissue glue around the edges. We had some technical difficulties. We were going to originally do this as a live surgery, but we'll do it as a recorded and sort of go into a little more detail than we normally would, so it is slower. This was in a patient with partial limbal stem cell deficiency from contact lens wear and also with a history of neurotrophic keratopathy. So the first step is to do a superficial keratectomy, and then you're going to remove the involved pathology as well. So there's a fibroblastic pannus that's often associated with limbal stem cell deficiency, so here I'm just removing that with a band of scissors and peeling that as well. And then doing quick measurements with the calipers. Here's the tissue as it comes pre-stripped. And just like in DMAC, to better visualize it, trypan glue can be helpful. And here it's been folded over, and I'm just going to use my DSS can to move it over in place, use a little more trypan to visualize the edges, and smooth it out. Unlike DMAC though, you can gently touch the edges and not worry about damaging your endothelial cells because there are none, right? And then just with more BSS and using the capillary reaction from your wet cells to draw fluid in an direction, you can smooth it out as well. I'll get rid of some more fluid and I'll punch the graft, making sure I still have my S stamp within that area. I've let the corner surface dry for a good amount, at least 5 minutes, and then we'll place it. And then I think a good thing is to press in the middle to get the interface fluid out. In this case, I actually had drained out most of the fluid, so there was none. But I would keep a wet cell at the edge, that way I can dry off the wet fluid as it's being dispersed from the interface. And then I usually try and keep my wet cell against the edge of the DMAC tissue. That way I can grab it, pin it down as I'm pulling the anterior cap off. Sometimes it doesn't always come off, and sometimes you need to go within with the cyclodialysis spatula and sort of free its edges and then go back and pull it down. And then the goal is to make sure it's in position and then to smooth it. If it's very laterally displaced, you can go underneath with a BSS cannula and just squirt fluid in the interface, and that can move it much more laterally. If you just need to move it a little, larger sweep-in motions are adequate, and we'll do that here. Are adequate to move it just like a 0.5 millimeter or so. You want to be within your epithelial edges and have a little space. Usually we recommend punching at least 0.5 under the measured area of where you measure with your calipers. That way you don't, if the epithelium is not close to the edge of your graft, there's less chance of having epithelial ingrowth. So once this is moved into place, then it's really just smoothing out the wrinkles. And so I like to keep a wet cell at the edge of the graft, so as I move out and squeegee that interface fluid, I'm collecting the fluid. Once I'm getting most of it out and the graft's not moving, then I'll actually try and get the last of these wrinkles out. To get these out, because they can be tougher as it starts to dry, I'll actually put fluid over the little wrinkles and move the fluid to the edge. That way you can lift the edge a little as then I squeegee out and quickly grab the fluid with the wet cell. So you'll see me do this in a couple instances here. We try to, and the reason why I kind of spend so much time doing this is because you want to minimize any of these wrinkles. That way, less chance of it sloughing off in terms of any movement of the graft post-operatively. If you look at anterior segment OCT post-operatively, sometimes you can see these fine areas of micro pockets of fluid. So I will actually put these patients on Miro 128 or sodium chloride 5% drops as well, 4 times daily. So we'll do this in this area as well. Smooth out these last wrinkles.
Alan, have you noticed if the graft gets really, really dry and you get aggressive, you can tear the graft? That's why you always have to have it a little bit hydrated on the surface.
Yep, I'm about to mention that in a little bit. I completely agree. I completely agree, because once I get the last of the wrinkles out, I actually do a pretty firm, slow pressure, because I've noticed that if you go too fast, I have tore one graft that way, because it was too dry, like you just mentioned. And I'm also careful to which part of the cannula I'm using, so I don't use the tip. I'm careful to use the elbow part, or closer to the elbow part as well. So here is just what you were saying. So during this part, I have to be actually very careful now to just firmer, slower pressure from the center out to get the last, hopefully, fluid out of the interface. But you can see how smooth it really looks there. Once this is smoothed out and you let it dry in place for about, I leave about 5 minutes. They recommend at least 2 minutes. I think you even use 10 minutes, Ed, right? Yeah. And it's pretty stuck on there, pretty adherent if you leave that amount of time.
Because really the only complication is graft dislocation, so it's got to be really, really dry and adherent. I mean, that's you want to avoid that at all costs.
Agreed. Most of my concentrate your tissue glue along the edges, but so I put that at the beginning and I'll smear it into the middle. And I'll use the front and then the fibrin, and then put a bandage contact lens afterwards. Sometimes it's so adherent. At the beginning, I didn't even put the fibrin glue in a couple cases, and it remained nicely in place and epithelialized over. But then hearing some colleagues have that issue where it gets sloughed, then I went back to doing the glue and the whole 9 yards there. So once it's in place, another 5 minutes of drying, then the bandage contact lens, and then the case is done. This is a different patient, but just wanted to be able to, because I had some better photos to show what it looks like post-operatively. Recurrent erosions, this patient had EBMD and epithelial-based membrane dystrophy and had recurrent erosions, despite having multiple keratectomies, even from outside doctors and with a diamond burr. We performed a DMAC surgery, and this is what it looked like post-operatively on sclerotic scatter. You can see the edge of the DMAC graft, but that's a beautiful thing of this compared to amniotic membrane. It's see-through, right? You use it for DMAC. You can see the subtle change on the fluorescein as well, with some negative staining along its edge. Here's about almost 3 years out. And the good thing is, like I said, she was having daily, if not weekly, if not daily, recurrent erosions, and she's been recurrent erosion free for that whole period of time now. So, anyways, possibly a new tool in our toolkit. Thanks so much.
Ollie first, and then Zena.
So great, very nice, Albert. So, so basically, you're using it as an alternative to amniotic membrane, and what we used to use, I guess, in the past. And the nice thing about it is that it persists, unlike amniotic membrane, it dissolves, and it doesn't cause haze because of the haziness of the amniotic membrane. So, I have a couple questions for you. One is how do you deal with a situation with partial limbal stem cell deficiency, where you already have healthy corneal epithelium in parts of the cornea, even maybe partially in the visual axis? And do you scrape that healthier looking corneal epithelium as well? I'm a little bit uncomfortable that maybe a small island of corneal epithelium is still there, but a lot of conjunctiva is already in the visual axis. How do you deal with that?
Sure, great question. Yeah, to be able to do the procedure, you are having a little collateral damage by removing that good epi, but you're hopefully making a better scaffold for the rest of that good epi to go all the way 360 around on the bright membrane. I have some patients where after I put it down, after doing the superficial keratectomy, you can see the late staining, but it stops at the membrane, and then there's just good epi after it. Josh Ho is actually, and he's the one who's kind of brainchild of his, where he's done this to analytics to have a central epi island, and he's removed that. I was worrying like, oh, that's their last little good island epi, and he said it has expanded over this, over this membrane. So not massive, but a little bigger.
Thank you. Zena, do you have a question?
Great talk. I think the
You
hard
want to use a microphone, Zena?
Great talk. That was amazing. I think the hard part's going to be figuring out, to your point, when you use amniotic membrane versus this. So I would say, do you get a feel of, this is better in sort of the moderate stage versus, early stage versus late stage? And then on average, how long is it lasting? You showed us a case that was, 3 years, but is that typical in terms of what you're saying? And then third, are you billing for a transplant code, not sort of AMT?
Great. You might have to refresh me on some of the questions. So, the first question, so where it fits in my algorithm, it depends, because a lot of it we can manage outpatient, right? So for those smaller, like small defects, I want to try a brand name Procera or a Cam 360 or a dehydrated, those are still going to be first. It's just so much easier to reach for those. And for the patient just to do it in the clinic for me. And at least actually to your third question, that's because it is billed as a transplant, so I need to do it in a surgery center.
Okay.
Or a hospital for the billing part of it. And then
Just how long it lasts on
oh
average?
yeah, it varies. It can be months. Because I have seen some shrinkage earlier on, months to half a year down the line. But then I've had some last years, and you can still see the S stamp, so you know it's there, or see it on OCT.
Thank you, Albert. In the interest of time, we're going to move on, and Dr. Basu is going to talk to us about minor salivary gland transplantation.
Okay. right, so minor salivary gland transplantation, it's been around for a long time. I'll just quickly take you through the concept and how we apply it and where it's relevant. So, you're essentially talking about patients with very severe aqueous-tear deficiency. And I think this idea of if the lacrimal gland can be replaced by the salivary gland, which is very similar in histology, has been around for a very long time. You've had something called the parotid gland translocation or parotid duct translocation. I mean, this used to be done quite a long time ago. I think there are some people who still do it. I don't know if you've ever seen a patient with a translocated parotid gland duct. So it produces this saliva in your eyes, but only when you're hungry. So when the parotid gland duct translocation didn't work out so well, people thought about using the minor salivary glands. The advantage with the minor salivary glands is that they don't have so much of reflex secretion, so you don't have to be hungry to generate fluid in your eyes or to chew, but it produces all the time. So basically you have to choose between whether you use the submandibular glands or the labial minor salivary glands. The submandibular gland has been used before, and the whole gland along with the duct, as you can see in the photograph, needs to be translocated again. So whereas in the parotid gland you translocate the duct, in the submandibular gland you take the gland along with the duct and translocate it. So it's a little bit of more radical surgery. What is easier to do is labial minor salivary gland transplantation, and that is what mostly has been done in patients with severe aqueous deficiency. So you're usually mostly choosing patients who have some kind of severe conjunctival cicatrizing disease. In my practice, that's mostly patients with Stevens-Johnson syndrome, but you could technically also choose patients with mucous pemphigoid. Sjogren's is not a good choice because they also have problems with the salivary glands. They have dry mouth as well, in addition to dry eyes. And there are other rare indications where this works really well. For example, in congenital allocrinia, where you don't have the lacrimal glands to begin with, or if you have some post-traumatic neuropathy, or also in idiopathic cases where you're not sure, but the lacrimal gland is not functional, but the salivary glands are. So very quickly, the surgical procedure essentially entails you taking out a chunk, which is called an en-bloc excision of the labial salivary glands, and then you make a small pocket in the superior fornix, hook the superior rectus, and the gland, actually the whole complex, the en-bloc complex, comes with a little bit of a sliver of the oral orbicularly oris muscle. So we anchor the muscle to the superior rectus, and then in that small gap that you've created superiorly, that's basically the entire en-bloc gland goes into the superior fornix, and then once it reperfuses, it starts to make saliva in the eye. So what's very interesting is that you can use fluorescein to first of all check in the lips what is the ideal site for harvesting these glands. So you can check preoperatively and see which are the glands that are functional and more likely to work, and take your biopsy or your gland, donor glands from there. And also post-operatively, once the gland has reperfused, you can just use a fluorescein strip and, like a Seidel's test, just paint the glands with the fluorescein and actually see the secretions to check if your transplanted salivary glands are working. There's not a lot of data on it, but we did a multi-centric study on this, different sites where we found that in terms of most parameters you had improvement, including in vision post-operatively. Patient-reported outcomes are really good. Just to give you a couple of examples, on top you have a patient that's a fluorescein stained photograph of before and after in a patient with Stevens-Johnson syndrome. Below also is a patient of SJS. So here you can see how the glands look here in the superior conjunctival area. That bleb-like thing that you see is just the overhanging conch, which can be avoided if you do the surgery, if you're careful doing the surgery. But what you also see in this is because the surface is improved and the wetness of the surface is improved, you have this remodeling of the corneal scar as well. So this is in a child. He's now 18 years old, but this is 10 years ago. So in this case, I have more than 10 years of follow-up, doing really well. And you can see in the last photograph, which is in this paper when we published, it was 48 months post-transplantation, and you can see how the luster of the surface is improved, and also the corneal scarring that was there earlier has kind of melted away and has become more clear. So I think the most famous case, this is another indication, is that you can use minor salivary gland transplants to facilitate corneal surgery in patients with dry eye. So in this case, I think this was done at the Bioscience Institute at Stanford. Andrea Kostler, she presented I think last year as well. So this has been presented all over the world. It is a very famous case, which was published in Cornea eventually. The case with very severe dry eye, post-SJS, where a type 1 caper was possible because a minor salivary gland transplant was done, and that enabled the type 1 caper to be done in otherwise what would have needed a type 2, and vision for the patient could be restored. Right, so that's all I have. Thank you.
Basami, comments?
Yeah, that's a great summary of MSGT. And one of the things that I really like about MSGT is that it helps us prepare for other steps of ocular surface reconstruction. And in particular, we can see sometimes a reduction in keratinization of the ocular surface. How do you go about counseling your patients about that timeline? What do you tell them to expect?
That's a great question. So usually these are patients with severe aqueous deficiency who are already on maximum medical therapy, possibly on scleral contact lenses as well. You are either preparing for a corneal procedure like prosthesis, or you just want to improve their comfort or their dependence on the lubricating drops. And so the main perception, they're more comfortable, and their dependency on frequent lubrication is less. So if you have a patient who's specifically looking for those differences in terms of what they're expecting, then that would be the perfect case. So usually my counseling is that these are the two parameters on which you can expect a difference, or if you're preparing for penetrating procedure which you would otherwise not do because it's severe.
Great. Thank you very much of the section on gene therapy. Dr. Sabater is going to talk about ocular gene therapy in patients with epidermolysis bullosa.
Oh, just a thought. Thank you. Hi, how are you? Well, nice to meet you. Perfect. Here it is. So my name is Alfonso Sabater. I come from Miami, from Dallas Consumer Institute. And today I would like to talk about an interesting case about a patient that had a very complex genetic disorder, epidermolysis bullosa. And I think what's interesting about this case is that I think it was really the first one where we treated a patient with topical gene therapy. So basically gene therapy eye drops. And I'll tell you a little bit more about this therapy because later on it has been now used actually in other indications still in clinical trials. But I think it was a very interesting proof of concept. So this was really a kid that we saw at Dallas Consumer when he was 4 years old. He came with really no relevant family history, but his whole body was wrapped in elastic bandages, and he had already bilateral contraction and syndactyly of hands and fingers, and his visual activity at that point was already impacted by significant symblepharon in both eyes. So this kid specifically, he had a type of epidermolysis bullosa that we call dystrophic. It's probably one of the most complex variants of the disease, where basically what happens is that the basal layers of the epidermis are impacted, and when you touch the skin of these patients, you can wrap the skin and it comes out very, very easily. So these, we sometimes call them like bubble boys, right? Because it's a very, very delicate condition. Really the gene that is impacted is the collagen 7 gene. That's the gene that is mutated. So when we saw the patient 2014, that was, here you can see the first picture, actually already in 2015, we decided to do a couple of surgeries. First we started with just symblepharon removal, we did amniotic membrane transplantation, we did oral mucous membrane grafts, we did plasma-rich growth factor, fibrin membranes, and the reality is that after 2 or 3 surgeries that were attempted in this eye, of course the symblepharon was just coming back, still was developing corneal ulcers constantly, and not only in the cornea but also in the conjunctiva, which I think it's basically why this patient also ended up having all these recurrences. So at that time we decided not to do any additional surgeries, and then in 2021 this is how the eyes were looking like. So we basically said, well, this is really a genetic condition, it doesn't matter that we do all these things, but if we can't really fix the disease, then there's nothing else we can do. So one day mom comes to clinic with the kid, and then she tells me, well, my son is being now treated with a gene therapy for the skin condition. It was called by Jubec, and what this gene therapy is based on is just inactivated herpes virus that contains the collagen 7 sequence inside the virus. So when you apply it topically in the skin, what it does is just provide the collagen 7 sequence into the cell so the cell can produce the right type of collagen 7 protein, which is basically the issue that would fix our patient's problem. So I basically contacted with the company that was developing the therapy. At that point it was in clinical trials, and we started working towards an ocular formulation just for this patient. So we did some in vitro studies, we did some mice studies just to prove that it was safe. Obviously it's a herpes virus, and ophthalmologists, we don't like herpes, but we could prove that it was safe for at least for the mice. And with that, and with all the data that we put together, we were able to get the approval from FDA to do this compassionate use in just our patient. So here's a quick video that just shows the surgery. We decided to treat the other eye, the eye that had not surgery before. And well, first just basically remove all the symblepharon. These kids, especially at the time of the surgery, it's complex because even the intubation is very complicated. Even just when you put your hands on top of his forehead to do the surgery, you have to be careful because in previous surgeries, actually he developed ulcers in the forehead just by the contact. So that's why we put those special drapes to protect the eyelids from the speculum. And then it's just a standard superficial keratectomy where we remove all the conjunctival tissue. And definitely there was already some scar tissue because there were many years with this issue. But anyway, the cornea, as you can see, looks pretty nice after removing all that scar tissue. We use amniotic membrane to cover the cornea and also the tarsal conjunctiva, so we suture amniotic membrane in there too. So right after the surgery, we started with the topical gene therapy. We did it, anyway, we didn't have data, but we know that corneal epithelium usually replenishes every 7 to 10 days. So we told the FDA we're gonna do once a week, and that's what we did. So what we saw actually is that month after month, the vision kept improving on the eyes up to a point where actually he was able to see 20/20 with just one eye, and that was after a year. But today actually it's already like 3 years that we've been treating him. I actually see him every single week, and he's still 20/20 on that eye. The other eye, we also decided to do surgery. This is the eye that had like 2-3 surgeries before this one, and his vision was after 5 months 20/60. Nowadays it's in the range of the 20/100. It's just gone down a little bit, but still, I mean, we've been able, I think, to recover the vision just with this weekly topical administration of the drug. We also keep him on blood-derived products. He was on them before, and also we keep him on daily low retinol. And with this combination, we've been able to preserve the surface of the eye. This is just a quick video of the patient that describes how impactful this has been for him, and I'll play it. I think it's an interesting one.
Antonio is a very special patient. that has a very rare disease with no cure.
Esta enfermedad es degenerativa y afecta todo lo que son mucosas.
Me costaba distinguir letras y números de juegos que juego yo en mi PlayStation 4. No podía verlo, tenía que levantarme de mi silla y acercarme a la pantalla para poder ver.
Fue muy difícil para mí cuando él me llegó a confundir. No sabía que era yo si no le hablaba.
That's when I started looking for alternatives. Antonio was being treated with topical gene therapy in the skin. He was getting positive results. I contacted his dermatologist. I proposed him to potentially start developing a therapy for his eyes using the same platform. It was probably around 7 or 8 months when Antonio was already close to having close to perfect vision. Of course, he's super happy with his vision now.
Y hasta ahora todo ha ido bastante bien, el tratamiento ha funcionado, el ojo se ha mantenido bastante bien.
Nosotros estamos muy agradecidos del doctor Sabater, siempre nos dio la fuerza y nos dijo que algo iba a encontrar, que una solución iba a encontrar para que Antonio pudiera ver.
Gracias por darme esta maravilla.
Better question?
The only comment I had is that what I said at the beginning, so this was really the first case with this platform, but now actually the company started recently a clinical trial for NK using this same viral platform. And anyway, I think this just opens the space for other conditions that we can treat with gene therapy.
Great, Alfonso, congratulations. I mean, it's fantastic. And these conditions are rare. I remember when I was in the UK, John Dart used to have a few of these patients, and very, very difficult to treat. One thing I'll just sort of ask you on, and you mentioned a little bit, is that most people are familiar with gene therapy in the eye and they look at AAV vector, and as you mentioned, this is HSV vector itself. Is that because of the size of the cargo that you're basically trying to do? Because it's a collagen structure, is that why HSV was basically chosen?
No, I don't think so. I think they could have used AAV. It's just that the platform that they had initially, the company actually, every indication that they have is based on this HSV platform.
Right.
And they prove it's safe and everything is around that one. So that's why we use that one. But I think AAV might be an option too.
And the half-life, you have to keep on, you mentioned at the beginning, I know you see it weekly, I can imagine, but how many times do you have to keep on delivering the therapy?
So after 3 months, we actually switched to, instead of doing weekly, we did bi-weekly. And we started seeing corneal ulcers. So we brought it down again to weekly, and then a weekly, it's been much better.
Right.
So I think it's somewhere between 7 to 10 days.
Absolutely amazing, congratulations.
Thank you.
Our final talk is going to be on genetic therapy for corneal dystrophies with Dr. Aldave.
Thank you very much. It's nice to see this many people in a room. Usually I'm talking on genetics or gene therapy, it's just talking to chairs. So thank you for being here. Now, by way of disclosure, I'm a consultant for a few companies, including Gene Edit Bio, whose product I'll mention during this presentation. So the question is, amongst many of you, why are we looking at gene therapy? Particularly, I'm going to talk about the TGF-beta eye dystrophies, which Dr. White spoke about earlier. We have treatments. We have phototherapeutic keratectomy, we have DALK, etc. Well, anybody who takes care of these patients knows that these treatments are not permanent. A patient of mine here with granular dystrophy type 2 had a very nice result after phototherapeutic keratectomy, vision much improved, glare decreased. Problem is she's still living, which is not really a problem, but that means that guess what? These are going to come back. And you can only do PTK so many times before the cornea gets too flat, too thin, or these deposits are too deep to remove with a laser. So we need treatments that are longer lasting for the TGF-beta eye dystrophies that don't risk the complications that we're all familiar with associated with keratoplasty. Now, if we're talking about gene therapy for inherited disorders, especially in this case of the corneal dystrophies, very quick primer. Some of these conditions are associated with what's called gain of function. A mutation occurs, in this case, in the TGF-beta eye gene. The protein is still made in the cornea, but it doesn't have its normal morphology. It takes on a different role, and it causes deposits. So the goal of therapy, therefore, is to try to inhibit the protein from being produced. And you see on the slide a number of ways of doing that, including targeted genome editing. So this company, Gene Edit Bio, has developed a protein delivery vehicle, or PDV, into which is packaged a Cas9 nuclease as well as the guide RNAs targeting TGF-beta-I. So this is CRISPR-Cas9 targeted genome editing for the TGF-beta-I dystrophies. The route of administration is an intrastromal injection targeting both the keratocytes and the epithelial cells, both of which are the source of the TGF-beta-I protein. Does it work? Yes, this is a paper that we have that's currently in preparation, about to submit. On the left images, we're looking at a cell line from an individual. This is keratocytes from an individual with granular dystrophy type 2. The blue circles are the nuclei, and on the image on the left there, those little purple dots are the TGF-beta-I mRNA in the cells. On the left are the cells not exposed to the PDVs. On the right is the cells exposed to PDVs, and we can see a knockdown or silencing of the RNA of the TGF-beta-I. Now, the other images we see, again, untreated and treated. In this case, we're looking at TGF-beta-I protein expression, and again, we're seeing a significant reduction in the expression of the TGF-beta-I protein in these keratocytes from a patient with a TGF-beta-I dystrophy. So, how are we going to apply this treatment? If you already have deposits in the cornea, using targeted genome editing is not going to help. You have to clear the cornea, either with a PTK or a DONC or PK. So this is a video from a first-in-human application of this therapy. This is a patient in China who's had phototherapeutic keratectomy, and at the time of the PTK, they're then receiving these injections of the PDV carrying the CRISPR-Cas9 targeting the TGF-beta-I protein. And you'll note there's 4 injections here, each one perilimbal. So you're targeting the limbal stem cell population and you're targeting the keratocytes as well. Treatment, as you would imagine, only takes a few minutes, quite easy to perform. So, where are we with this? The company's investigator-initiated trial is ongoing. There have been 7 patients enrolled thus far in China. In January of this year, they obtained FDA clearance for a phase 1/2 study, which is called the Clarity Study. And we're hoping to initiate enrollment of patients in this study sometime early 2027, so not very far off in the future. Now, what about the endothelial dystrophies? We just had a nice session regarding some advances in management of endothelial dysfunction. We saw some beautiful videos. Dr. Basak did not do that, fortunately, but I have seen that happen here in the U.S. at UCLA, training our residents and fellows. I've seen that all over the world since I do a lot of DMEC training internationally. And this, yes, that does not increase the cell density doing that. So we see the masters at the meetings. We see these large published series. Keep in mind, those published series are usually single surgeon or several surgeons who are experts. That is not necessarily the real-world data. This is real-world data. This is from the Eye Bank Association of America, looking at the rate of primary graft failure and early regraft. Primary graft failure is basically failure of the graft to function. The surgeon says the surgery was flawless, but that darn DMEC graft never worked. Early regraft is when a surgeon orders another tissue for a patient without telling the eye bank exactly what the reason is. We know it's probably surgical manipulation. If you add those up, in the green line is the early graft failure and primary graft failure rate for DMEC. You see it's around 50 out of 10,000 cases, 2.5 times higher than it is for penetrating keratoplasty. So there still is a significant learning curve, and this is domestic data in the US. Also, if we look at outcomes of endothelial keratoplasty in a pediatric population, even in the experts' hands, like in this article from Elbrick Prasad, this is Dr. Ramappa, who has over 1,000 patients with CHED in his practice, with whom we're collaborating on gene therapy for CHED, which I'll talk about in a moment. He's published the results of DSEC for a large population of children born with corneal edema. Most of these kids have CHED. You can see on the Kaplan-Meier survival curve that at 0.5, you draw a line all the way across, the average survival is 10 years. Given the fact that the average age at the time of transplantation is 8, that means half these kids have a failed transplant by the time they're 18. And we know the next transplant is going to last a shorter period of time than the first transplant. This is best outcomes possible because he is the world's expert. So we need better treatments for endothelial dystrophies, especially CHED, for example. CHED is an example of a loss of function dystrophy. in this case a protein, it's an enzyme, SLC411, that's critical to endothelial function, is not expressed. So the goal of treatment for this, or for macular dystrophy, is to introduce the protein into the cornea. And this very important article was published by Joe Bonanno and his colleagues in Ophthalmology Science a number of years ago, in which in a mouse model of CHED, they delivered the SLC411 protein using AAV9. They performed a single intracameral injection in one eye of these mice, and then followed them over time. You'll see in the right eye, this is the eye that's not injected, a progressive thickening of the cornea from day 0 to week 4. In the left eye, the eye which they did the intracameral injection, you see the corneal thickness is relatively stable. So they showed decreased corneal edema in the treated eye compared to the untreated eye with a single intracameral injection. I was quite struck by that paper, thinking, wow, it's amazing, but I bet we could probably get a higher percentage of the endothelial cells transduced if we did an intrastromal injection instead of an intracameral injection. So in our lab, we've been, over the last 3 or 4 years, looking at gene delivery with an intrastromal injection. In this case, we've been using AAV8, and you can see in this mouse, on the control eye, how edematous that cornea is week 14. Same mouse, other eye, week 14, you see a very compact cornea. So we have shown significant disease-modifying activity in this mouse model of CHED. So where are we? We've been fortunate to be granted rare pediatric disease designation and orphan drug designation from the FDA in 2024. We had an Interact meeting with the FDA also in late 2024. We have recently completed a non-GLP tox and biodistribution study. We're planning to submit a pre-IND meeting package to the FDA later this year, and we're hoping to submit an IND application sometime early 2028 with a first-in-human clinical trial starting in mid-2028. So gene therapy is coming. It's coming for both the TGF-beta dystrophies as well as endothelial dystrophies such as CHED. Thank you very much.
Tony, that was great. Very exciting to see what's coming on the horizon. Just a comment on your vector. You're using AAV8.
Correct.
Can you just elucidate your choosing of that vector specifically? Because I know obviously the vector guys use AAV5, but just your choice of vector for that.
Yeah, when you're choosing an AAV vector, primary thing is tropism. What sort of cells does it like to transfect? And AAV8 has been shown to have high specificity for the corneal endothelium, which is of course our target, and so that's why we chose AAV8. Also, there have been some work done in large animal models using AAV8 targeting other corneal conditions, in which they showed low immune response, low percentage of these animals developing serum antibodies to the AAV. So for those reasons also we chose AAV8.
And for the CRISPR-Cas9 for the TGF-beta-I, are you concerned at all about, I mean, TGF-beta-I is one of the most expressed proteins in the whole of the cornea, and if you're knocking out with the CRISPR-Cas9, are you worried about off-target effects? I mean, you may get rid of the deposits, but you may also get rid of part of the decimate membrane as well, because of course you get a high expression in the DM as well.
Yeah, so the question is, if you're trying to knock out this functional protein, TGF-beta protein, do you have to selectively knock out the mutant allele? Or if you silence the wild type as well, are you going to see any detrimental effects on the cornea? This is silencing both the wild type and mutant allele. I don't think that Cas9 is specific for the mutant. However, think about the patients who are homozygous TGF-beta dystrophies. We don't see a lot in the US. EK Kim in Korea sees a fair number of these patients. Other than where the deposits are, the corneal thickness, the corneal clarity, etc., is normal. So based on that, we feel that you can actually knock out TGF-beta protein expression in an adult and not suffer any adverse consequences such as loss of corneal clarity.
Okay. Really fascinating stuff. Unfortunately, we're out of time. We could talk a lot more about this, but we look forward to gene therapy for the future. We can take a 5-minute break. We have to be back at 5 o'clock for the next session.
She asked me tonight. Algo tengo en mi sangre. Oye, ¿qué está hablando contigo?
¿Ves lo que te digo, güey? Que no solo aprendimos y lo hiciste. Es colonización. Colonización 3.0.
¿Y qué importa? Siempre va a venir, pero la vez de vos. No, fue como 8 horas, llegué recién.
Tú vas a México, yo me entero, güey. Algún día. Trabajo.
Sí, ya sé cuál es. No, es caramelo. Sí, ya sé que es demasiado. Sí, mayo. Sí.
¿Hace mucho frío?
Es que hubo unos días con 1 hora de frío y ahora cuando vine, menos 4 grados. ¿Qué es eso? Frío, invierno.
¿Todo bien?
Sí, todo bien. ¿Tú bien? Ay, no, I want to go back to
No. Está lloviendo. Por eso me No, verdad, no ha sido atacante. ¿Cuánto, no?
We got this one. Easy.
afternoon to all of you staying for the last interesting session about keratoconus. I'd like to invite the speakers, the panelists to join us. Dr. Baraker, Dr. Fogler, Dr. Hernandez, Dr. Hanuk, Dr. Cipiedo, Dr. Pereira, and Dr. Torpetti. He will not be able to join us, unfortunately. And our colleagues in the US. Hello, can you hear us?
I can hear you. Can you hear me?
Yeah, great.
All right, sounds good.
So if I understand correctly, you'll be showing us a CTAC procedure, correct?
Yeah, we're going to do a CTAC live on Zoom for you.
And you've already done the femtosecond pocket, if I understand correctly?
Yeah, so our patient's right here, ready to go. He knows he's being recorded or streamed, but we're ready to start the surgical procedure. But I'll go over what we did at the laser just so we can catch the audience up to where we're at for the procedure.
Okay, that's great. So please go ahead. We're here watching you.
So what I'll do, let me just give you a little background. Let me just share a screen. I'm just doing a check here to make sure it goes. And I'll ask my tech team to give me the thumbs up when the screen shows, so I can't see it from where I'm at. But the story is our patient here, he's 34 years old. He's got fairly advanced keratoconus. And he already had transplant on the left eye. After the transplant, he had some issues with elevated pressure, which led to glaucoma and limited vision. So we're really trying our best to do something non-transplant to minimize his risk. And so it would be CTAC for the right eye. What I can do is I can show you a copy of his topography. This is his Pentacam. And then on the next page, we can show the CTAC plan, which has been run through the nomogram. And things that I would call out, this is a thicker segment. We're going to be doing a 500 micron segment. And it's going to be, the incision axis is at 150. So we'll show that at the microscope. So let me just get the lid speculum in, and we'll get our microscope light on, and we'll switch over to the cervical view, and we'll get things done. All right, Hunter, I'm going to put the lid speculum in for you. Lots of bright light for a couple minutes. And you're just looking right at my light center. Good job. What we did is we measured the pupil center at the microscope, and it was a 2 millimeter over from the pupil center. Oh, this is 2, that was the wrong one. So we had pupil center and over 2 millimeters, and then pupil center down 2 millimeters using 2.5 millimeters, sorry, for his plan. And that gave us the marks to where we're going to recenter our treatment. And then the little purple circle you see is just the 4 millimeter optical zone. So that just shows us the offset from where we're going to make it, or where we did make the channels. And then the 150 degree axis is already measured. All right, look down just a little bit for me, Hunter. Thank you. Now let me just turn the display on. So the first step is just get into those channels. And so this is a little dissector. We're going to get into our CTAC channel. And I like to just open up the first couple millimeters going clockwise and counterclockwise. We use in our surgery center, we have a Alcon Lens X femtosecond laser. I'll take clockwise or counterclockwise. And that's what we use to make the channels. Hunter, just look right at my light again. Good. So once we get the channel started, we're going to go ahead and dissect. Here we're going clockwise. And the CTAC segment here is relatively thick and large. So this dissector is a little bit thin. So I like to sort of wiggle, if you will, a little bit as we enter the channel to really make sure that it's fully open. And we're also looking to make sure that we're never pointing the dissector up. These channels are made at 200 microns of depth. And so we want to make sure we never come up through the cornea. That would cause some issues. We'll dissect the other direction. And I'm trying extra hard to make sure I stay on screen for you guys. If I move off, just give me a little nudge. Sometimes hard to watch everything all at the same time. Get a good 360 degree dissection. It looks like it's open pretty nicely. Now, a little trick that I learned from Bill Wiley was to take the segment. I'll take the CTAC segment and of course it. And I'm gonna put the CTAC segment on the eye, just on the surface of the eye. And what you can't see is behind me on the wall, I've got the the surgical plan hanging up. You know, I'm going to mark the approximate start and end points of the segment on the cornea, because the CTAC segment can scrunch itself up a little bit in the channel. So I want to make sure that we're fully extended. So I'll just use an LRI marker or a toric marker to put a mark here. This is 15 degrees away from our incision site, and then we'll put another mark here. And these are just approximate marks, so we know when that CTAC segment is all the way open. Okay, and now we're ready to get the segment. Can I take a second forceps tire or two forceps? Either one's fine. All right. So I'm going to try and insert the segment counterclockwise. I think that'll be the shortest trip for the CTAC to take in the channels. And I like to grab a good section of the segment with this insertion forceps, something like that. Because for the first clock hour or two, this is going to want to squirt itself back out of the eye. Let me just make sure I stay centered. Yeah, under a little pressure for just a minute. Let's introduce the segment. Then I'm going to hold it with the tire so it doesn't back out. And then we'll push a little bit more. And then a little bit more. From here on out, this should go almost on autopilot through the channel. And when I'm about 50–60% done, I'll take the smoothing ball, the little ball there. And what you'll see here is there's a little bit of wrinkling of that CTAC segment. So we're going to just iron this out using this little ball. And it's going to stretch itself through the channel. There we go. Good job, Hunter. Okay, I'll take the forceps again. Okay. And now we'll try and get the channel the rest of the way in. But as we push, we're going to want to let this extend out. And this is about as thick as the segment's going to get at 500 microns. So you can see it's like pushing a little inchworm into the eye, and as it goes in, we're going to smooth it out for him. I'll take that little smoothing ball again. We're just going to work this around. There we go. So now we've just about hit our mark, so we know that we're all the way on one side, and now we'll smooth out the other way, and we should be pretty close. Yeah, we're right on it. There we go. Hunter, just look right at those lights for me. I like to put a fair amount of pressure with this little smoothing ball to really make sure that that segment is all the way unfolded in the channel. And I think I might back it up just a little bit. Try to take that texture. There we go. I'm going to back up the segment just maybe a few degrees, but we are already pretty much right on our intended mark. Just a little bit backed up. All right. All right, so guys in the audience, that is a CTAC surgery. The segment is all the way in. Hunter, how you doing down? Questions or comments while Hunter gets in the OR as we move people around? Any questions or comments or concerns, guys?
So you mentioned, could you repeat how you do the marking? Because that's not something that we saw, that's something that you did before.
Yeah.
What do you look for when you do the marking?
So there's three components to the marking. One of them is the axis of incision. And so I actually mark the axis using what's called a robo marker, but it's basically as if you were marking for a toric IOL in pre-op. So for him, that was 150 degrees. And that helps you align where the incision into the cornea is, or the entry incision for the CTAC. Now, on the surgical plan, there will be a map where you measure from the pupil center, and the instructions are all given to you by the nomogram from CorneaGen for CTAC. And they'll ask you to measure either over or down a certain number of millimeters, and that's where you use these little, let me take these little, so they have these small calipers. I'll see if I can get this closer to you. They've got these little calipers. It'll be hard to get that in focus. Let's see if we can, we can do the microscope speed too. That's good. But then just hit the focus button so you can get it. But they have these, that's okay, I'm too close. They have let's switch to the scope feed, guys. Yeah. So you can see this is a 4 mm offset mark. They've got all these different distances, 3.75. And you basically just mark down and over. So you mark down and over from the pupil center, and that tells you where to recenter the treatment zone for the channels. It's a little bit harder to explain than it is to see on the map itself, but that's all done prior to going to laser, at least here. Some people can actually do that under the laser.
So, yeah, Dr. Carlucci.
Hey Brandon, Sadir here from Cagliari.
Thank you for doing. I don't know if you heard me, Brandon. Sadir here from Cagliari. Can you hear me?
Hey, Sadir. Nice to hear you anyway.
Yeah. Thank you very much for doing this. Fascinating stuff. Just curious, did you create the tunnels earlier today or on a previous day?
So I created the tunnels about 15-20 minutes before the live stream, and that's just because we have the laser right here outside the surgery center. But you can make the CTAC channels, a day or even a week, prior to the surgery. So if you don't have easy access, then our patient's going to be cutting by. But there we go. Thanks, Hunter. Appreciate it. You can make those channels with up to a week, maybe even more before the surgery. So if your laser is elsewhere and your OR is down the block, you don't have to do it the same day. We're kind of spoiled here, right? I can do it the same day, which makes it a little bit easier for us.
So you're comfortable opening these channels a week or two later? If you have to, not ideal, I understand, but
maybe not ideal, maybe harder. I've had colleagues across the country, Sadir, who said that it really is not an issue. I don't think you have to open the channels the day you make it, because the question that came up was, if I make the channels, should I open them and then let them heal and then open them again in the OR? And you don't seem to have to. Now, that is not firsthand experience. That's experience that's been given to me from other patients, other surgeons. In particular, it was Bill Wiley. He will often make the laser incisions several days to even a week prior to the surgery itself.
Thank you very much. I think that's a great question because not everyone has a laser platform, and that was going to be also my next question regarding the docking. What is your experience, especially in irregular corneas, and are there different systems that are more suitable for such corneas?
Well, I've only used the LensX for CTAC, but others have used the IFS. You can use the Zemer. There's several lasers you can use. I've been remarkably surprised at how relatively straightforward the docking has been. Now, you do applanate for these channels, and so I was worried about wrinkles in the cornea because these are conical corneas. They're not typical, but so far, we really haven't had much issue. We do a lot of verbal anesthesia, just making sure that we can center the treatment on either the pupil or the new treatment zone. And we do have the ability, at least with the LensX, to move that treatment zone. So if patients aren't docked perfectly center, there's a couple millimeters where we can digitally move the treatment zone to make sure it matches the map that was given to us by CorneaGen. So I would say overall easier than I thought it would be to get these patients docked.
No, I need to open it.
This one? Okay. Can you hear me? I am Rafael Barraquer from Barcelona, Spain. I didn't understand exactly what were the goals of your this surgery. Are you trying essentially to correct more of the astigmatism, or are you also trying to correct sphere, and what about coma? Or you?
So the answer is yes to all of them. I mean, our goal with CTAC surgery is to. I'll give you a little bit of what we've done for patients and how we select them. We're looking for patients who have pathology probably in the central 6 millimeters or so of the cornea. I like my patients to have the best corrected vision. My own rule is 20/40 to 20/50 or worse. So the patients who are not functioning well with either glasses or contact lenses, we don't want central scarring. I can't comment much on coma. But what we've seen in our own series, and we actually just presented a series of patients at our ASCRS meeting, where we overall saw, within a month of surgery, saw an improvement in best corrected vision of a little over 2 lines, and about 6 lines of improved uncorrected vision. We also saw reductions in sphere, cylinder. Of course, we're reducing the spherical foot as well. Patients are starting out very myopic and ending up less myopic. I can't make a comment on coma yet. The higher order aberrations are a little bit higher, but what you tend to see after CTAC treatment is centralization of the astigmatism and improvement in the regular pattern. So they tend to be much more correctable, and that's why we're getting our improvements in vision. And we did our analysis at 1 month for best corrected vision after CTAC. I do think with some of the epithelial remodeling, you still see a little bit of a trickle effect and improvements over the course of probably 2 or 3 months. But our real world goal with these patients is get them to see anyway, anyhow, without having to do a keratoplasty.
But this particular patient had the implant was in the lower part of the cornea, the central part of this ring was so this was the positive or the negative axis of the astigmatism.
So it was basically that was in the positive axis of the astigmatism. He was with 180. And we're basically trying to pick up that cone to regularize the corneal shape.
Yeah.
Okay,
of course.
We need to proceed in order to be on time with the next talk. Brendan, I don't know if you would like to stay with us for the rest of the discussion. That would be nice. Otherwise, if you have other patients, of course.
I can try to, but I gotta keep rolling with patients today as well.
So thank you for this beautiful surgery. We'll come back to CTAC and CARES during the rest of the discussion. Thank you very much, Brandon. I'd like to...
Thank you, guys.
All right. I'd like to invite Dr. Gomez to speak about the global, maybe there, about the global consensus on keratoconus.
Thank you for the wonderful meeting and the time here in this beautiful island. My talk is unmet and unmet needs for the global consensus on keratoconus. This is my financial disclosure.
Can you please include the time on the slides? Thank you.
Not related to this talk. And as we know, over the last decades, there has been a revolution in the knowledge of keratoconus and corneal ectatic diseases. However, there is still many controversial aspects related with these conditions. So, thinking about that, the 4 supranational cornea societies, including Pan-Cornea, Asia Cornea, EU-Cornea, Cornea Society, decided together to do this first global consensus of keratoconus. This was the first important initiative between the cornea societies in this direction. So this project is started in 2013 and we finished 2014. That was presented in 2015 and the article came in 2015 and that was the most cited article in Cornea Journal in the last years with more than 1,200 citations. But in the last 10 years, a lot of changes happened, both in diagnosis and treatment. So with this in mind and being part of the methodology of the Delphi panel that needed to be updated every 10 years, we decided to start the second global consensus. This consensus had myself, Renato Ambrosio, and Farhad Hafezi as the main coordinators. We tried to be more inclusive, involving not only the main cornea societies, but also the keratoconus new societies and the refractive surgery societies. We also tried to be less biased in terms of coordinator selection. Coordinators are the people that make the questions. And we performed a very nice literature search based on scientific evidence that was distributed to the coordinators and panelists. So the methodology was the Delphi +1 method, exactly the same as the first consensus, in which we select the topics, then the society select the coordinators and panelists with proven expertise in the field. All of them had access to the literature search, and the panel was organized with the preparation of the e-questionnaires. The panelists were polled anonymously, and answers were tabulated and analyzed for subsequent rounds. As a general rule for consensus, it was defined when you had 2/3 of agreement. So after the first round, we had a presential round, a final round, that include the presentation of all the results from the different panels and the validation from the whole group. So just a few numbers, we had 121 participants, 4 online rounds and 1 face-to-face meeting, the Delta +1, and over 200 questions on keratoconus and ectatic diseases. 7 thematic groups or panels were established, differently than the first consensus in which we had only 3 panels. This one we included definition and diagnosis, staging, clinical treatment, cross-linking, invasive rehabilitation, keratoplasty, cataract and keratoconus, and elective refractive surgery. So I will present briefly a summary of all these 7 groups or panels. Starting from definition and diagnosis, we reviewed the definition of keratoconus and we included the major diagnostic criteria. The 2 first were mandatory. There's an abnormal stiffening of the anterior and or posterior corneal surface and abnormal corneal thickness profile. And this was accepted as in a consensus with almost 85% of agreement. Regarding classification, that was something that we could not achieve in the first consensus. This time we tried to get one of the most cited grading systems nowadays, which is the Bellin A, which is anterior curvature, B, posterior curvature, C, thickness, pachymetry, and D, visual acuity, which considers the measurements based on tomographic shine fluid equipment. And then we got this classification to use as a base, and we tried to simplify it in 3 keratoconus severity grades, the mild one, moderate, and severe. So as you can see here in this shine fluid maps, you can see here a keratoconus that was graded with the belly as A1, B1, C1, D1. This is considered a moderate keratoconus, and in the other eye, just one grading that is C1, the other one 0, that is a mild keratoconus. And this was accepted as a nice classification, simplification of the ABCD Belling's classification. So then we decided to ask the panelists if subclinical and form-fused keratoconus should continue to be used, and most of them agreed that yes, and it should be considered as preclinical stages of keratoconus. Being subclinical keratoconus, when you have some topographic signs or tomographic signs of keratoconus, but not enough to diagnose keratoconus, and the other eye with keratoconus. And form-fused, when you have almost normal signs and keratoconus in the contralateral eye, but usually is a non-progressive disease. When you have both eyes without keratoconus, but some suspicious signs, then we included this as a suspicious keratoconus nomenclature, and those patients need complementary exams and follow closely. In terms of keratoconus in children, the first panel agreed that children with corneal astigmatism more than 2 diopters in subjective refraction, they should undergo the complementary tests. So this was consensus. Ectasia progression was a very controversial topic. The panelists agreed that the definition of progression should include measurements of the anterior, posterior, curvature, thickness, and vision. However, most of them still relies on Kmax measurement. So more than 60% still use Kmax as a measurement of progression. Although they realize and they agree that it does not reflect, it's not a very reliable and reproducible measurement. So they need to do a better way in terms of evaluating and defining progression. Group 2, they evaluated clinical treatment and non-invasive, so clinical measurements to halt keratoconus progression, verbal guidance, use of topical anti-allergic medication, lubricants, non-surgical management for keratoconus, including the spectacles, contact and scleral contact lens, and approach to clinically treat corneal eye drops. Cross-linking should be offered for patients with tomographic and topographic progression. In pediatric patients with confirmed topographic and tomographic keratoconus, cross-linking should be considered without waiting for progression. So that was new. And for keratoconus without documented progression, the following sub-criteria should be considered. Oral hypoflavin and sunlight exposure cannot replace cross-linking. Group 4 evaluated invasive visual rehabilitation, so PRK, if it's considered, should be associated with pre and peri-operatively cross-linking. When combined with cross-linking, the use of mitomycin is not considered by all surgeons, and transepithelial PRK is more adequate. About intrastromal corneal ring segments, if cross-linking and the rings are indicated, there is no evidence to define the best sequence. Rings cannot halt the progression of keratoconus, but help centering the cone and diminish coma-like aberrations. And those are the minimum requirements to consider phakic IOL in keratoconus patients. Keratoplasty approaches, still doubt should be the preferred choice of keratoplasty, unless specific conditions indicate the need of PK. And very interesting, different from the first consensus, nowadays, if surgeons find DSME or do a perforation during surgery, most of them try to continue the procedure. Refractive surgery, refractive surgery, corneal tomography is a mandatory tool for planning the surgery and for screening patients. If patients already treated with the rings and cross-linking without progression, phakic lenses are indicated, and a toric phakic lens should be indicated when astigmatism is greater than 2 diopters. Group 7, cataract surgery, concerning IOL calculation for Kmax more than 50 diopters predictably decrease. A multimodal formula is recommended. Slight myopia should be targeted, and discrepancies between anterior-posterior curvature lead to predictable results. So finally, we propose a treatment flow chart that includes different items and all the new surgical procedures. So the take-home message is that the global consensus updates the finding of the first global consensus, covering all the current aspects of these conditions. The panel emphasized that contemporary assessment and classification must extend beyond anterior curvature alone. Scheinflug and OCT with all the measurements, and in selected contexts, biochemical assessment are recognized as important tools. From therapeutic point, the consensus reinforced cross-linking as the main treatment for stabilization. Beyond stabilization, we provided a structured guidance for visual rehabilitation, including all strategies and surgeries. Unmet needs, we found controversial, still a very controversial topic regarding the definition of progression. So better definition is needed. The panel also recognized the need for better evidence of the role of new diagnostic devices, multimodal analysis, and IA, and better definition of the efficacy, nomograms, and long-term safety of the new treatments is needed. It's very important to understand that a consensus is not a Bible, it's not a systematic review, it's not a prospective randomized study. It's a photograph, a snapshot of experts' opinion, and according to the methodology, this needs reevaluation. It also makes a very clear idea about the limitations of the evidence that we have nowadays and the gaps for future research and innovation. So with this in mind, we also are planning and opening space for new evaluations, for new consensus in the future. So the paper was just released in Cornea Journal, now it's available, and for better the details, I invite you to read the paper. Thank you very much.
Thank you very much for the comments. Are there any questions from the audience, from the panel? Yes.
Perhaps a short comment. I liked a lot that the new definition incorporated the concept of inflammatory mechanism. Many papers are coming out showing that inflammation may be beyond eyes and also systemically. We have like indirect ends like atopy and many comorbidities, systemic comorbidities. Do you think that the next step will be to consider keratoconus a systemic inflammatory disease with an ocular manifestation?
It's a very interesting question. I think yes, probably in 10 years, the third consensus, we must change the definition and including more information about the physiopathology that is still, we are still learning a lot, not only locally, but also systemically. So it's a very, very good question. There is a lot of things about even microbiome interaction with the eye, the gut-eye axis, and that is also interfered in keratoconus patients and allergic eye diseases. So there's a lot of things that we need to learn, but definitely I believe that we can update the definition in a few years. Very good question.
I have a question. If I understand correctly, then about 92% agree that Kmax is not reliable for progression, but at the same time, 75% of the people still use it. So maybe to the panel, how do you define progression? I'm curious to hear.
So maybe refraction is still a good measure. I think increasing one diopter for a period of 6 months up to a year, K mean and K max, looking at the posterior elevation as well. I think you need to take into account not only one parameter, but go through all of what you have available then.
Yeah, I think the ABCD classification is very wise in that sense because you have to measure the anterior elevation, the posterior elevation, and the thickness. Maybe for me the thickness is the least important, but the argument would be which is more important, the anterior or the posterior elevation. I think most experts favor the posterior elevation of the more sensitive parameter.
For me,
okay.
For me, we must understand also the importance of the aberrations. So over time, I think we have to learn more about that, and I think it's going to be another good point to see progression.
I agree with everything you said. I just think these are really expert point of views, and it's not logical that all the patients with keratoconus. We need to give people also easy metrics to decide whether there is progression or not.
May I add one thing? So
yeah.
Even in the global consensus, what is crucial is not K1, K2, K mean, K max, whatever, is that the change is more than noise value.
Exactly.
And that you can have it in every, so at the moment we have it embedded, for example, in the SICSSO device. You have it for every stage of keratoconus, you actually have the confidence interval. And for example, also in the ABCD, you have it but not for every stage. So for example, there are many papers. So what is crucial is whichever one you like. I don't like Kmax, but if you like it, go for it. But you need to know the noise value for that particular patient. So you cannot use the 1 diopter for a 42 diopter and the 1 diopter for a 60 because it doesn't work.
The noise is different. And what
Yes.
do you use?
At the moment, I am biased because I designed that display. So I use the MS39. In the MS39, we have done a huge study with 2,000 keratoconus patients. So basically, when you use two values, you have all the indices that you want, and based on that specific patient, it's going to show you the confidence interval for that specific patient, for that specific stage for keratoconus, for every index that you want. So bathymetry, elevation, anterior, posterior, thickness. So if it changes by 3 microns, that is a very early keratoconus, you will know if it is significant or not.
And regarding the comment of Dr. Barraquer, what do you think is more sensitive for early keratoconus? Is it the posterior or anterior changes in your model?
So that depends a lot. So there are some patients that change more in posterior elevation and others they do not. So I don't think that keratoconus changes all the time in the same way. I had patients that got thinner before going to get steeper and other that got with anterior elevation. The other question is, if you have a patient that is increasing with only posterior elevation, would you do cross-linking? That's a much bigger debate, because there is no change in nothing, so you might want to...
Would you?
I wouldn't. I normally, if I have only one parameter changing that is not anterior curvature, I normally wait.
So indeed, that answers also my question. You still rely more as a single parameter on anterior change, not on posterior.
No, so what I'm saying is that I do not think that I would suggest a surgery that does have complication if the parameters that are changing at the moment are not changing at all the quality of life of the patient. So but if you have a change in anterior curvature that will change the quality of life of the patient, then I think that the balance between risk and benefits is higher.
I cannot agree more, but what brings me another question is, should we change the division of progression according to the age of the patient? Should we be more sensitive to many minor changes in children? And if we've got a 45-year-old with a 60-year-old cornea, then progression is more likely than 2 diopters. No? So I think we need to take into account not only the cornea, but the patient itself in addressing progression.
If you look at the consensus in children, we should not wait.
Yes. No, you should not wait for cross-linking, but still with patients that have cross-linked, do you not check them for progression after cross-linking?
I do not. I don't know what's the experience of the panel. I'm curious also to the audience and the panelists. I do not immediately cross-link children with a diagnosis. I would like to see some evidence of progression. Even if very minimal. I would not wait the same like in an adult patient, but I would not immediately cross-link him, and it very much depends on the age, right?
I think
someone who is 16 is not someone who is 11.
In any case, if there is some debate on what can we define progression in a normal patient, I think it's even more difficult after surgery. I see that the consensus states that there is the intracorneal ring implants do not stop the progression. I think there is also evidence to the opposite. Recently, for example, there was this series of pediatric cases of keratoconus implanted with rings and followed for 10 years. And one of the conclusions is that they did not progress without any kind of cross-linking. So, I don't know, maybe there are different populations.
Dr. Fogler wanted to add something?
No, I think besides looking at objective measurements, in the clinic we often ask the patient in terms of the vision and subjective feeling, is the vision same as last visit or your vision has dropped? If the patient says my vision is exactly the same and you find there is no drop in the vision, then only looking at objective parameters, what your machine has showed you, and you say that you are progressing, may not be the right measurement. And in fact, looking at the thickness measurements from tomography devices in keratoconic eyes, I think ASOCT thickness measurements are far more reproducible, accurate. So even post cross-linking, I think you should not look at tomography thickness, because change in corneal density often gives you thinner corneas when they're actually not thin. So we should make it a point only to look at the ASOCT thickness maps.
Most surgeons that indicate cross-linking at the diagnosis of children are based on 88% of progression of a paper published. But we need to remember that there are some bias in this paper, a lot of bias. It's a tertiary center, patients are evaluated just based on tomography. So you should not forget the medical treatment of those patients. Allergy, surface, so I usually see the patient, and if there is no progression, I usually don't do cross-linking at the diagnosis, even in children.
Most patients with keratoconus in children, we assume that they have some component of inflammation and allergy. So we always initiate lubricants, anti-allergics. And even if you were to plan cross-linking, I think it's always better to get the surface to quieten down and then do the cross-linking. Because if the surface is active and you do a cross-linking, maybe you're more likely to fail. Your cross-linking may not. So always pre-treat and then reassess. Sometimes when you pre-treat and the patient comes back, you find your parameters have improved.
Okay, that's good to hear that there is a lot of nuance. So if I summarize this discussion before we go to the next talk, I think the clinical complaints of the patients are leading, things that can influence patients' quality of life. They are the most important. There is a lot of noise in our measurements, but there are new devices. We hope that they will reduce this noise. When we look at these parameters, we should look at several parameters, and we should look at progression compared to what should be the noise in that degree of keratoconus and in that age, and also in children. It's okay not to immediately cross-link them. You need to look carefully. You need to treat associated diseases. You need to make sure that this is a significant condition before you do something that could have complications, especially in children. With that, I'd like to invite Professor Chod Mehta. He will give us the talk. Unfortunately, Dr. Awad is ill and could not join us today, but we're very happy to have Chod here. He will talk to us about updates on femto care.
Okay. So, good evening, everyone. So, thank you for staying back, and I appreciate that. I am standing between you and a nice meal and some alcohol as well. So, you can continue the discussion later on. So, I'm going to give you a little update on femto cares, and Shadi was very kind to cut the slides down from 56 to 49 for me. But anyway, we'll try our best here. So, let's go. So, cares is an acronym for corneal allogenic intrastromal ring segment, and I learned at lunchtime today with Rajesh and Vito that if you plug in cares into ChatGPT, it will talk to you about doing some appendix surgery in the eye that's only selected available in certain centers. So don't believe everything you see on ChatGPT. This is the characteristics of cares. It's an allergenic material. There's certain things to think about, which we'll talk about in a little more detail. The optical zone sizing, as you saw from Brendan's basically surgery, generally varies from 4.5 to 6 millimeters. I'll tell you what size I will basically do. And the depth, of course, can be programmed. Most of us use lasers when we're putting in care segments, and typically between about 250 up to about 330 microns is the depth that we put our care segments in as well. And obviously, the material is allergenic, so it shouldn't basically melt, and we'll talk about this in a little bit more detail as well. Okay, this is what the segment looks like if you don't basically do the surgery yourself. At the bottom, you can see that sort of segment, basically line there of tissue similar to what we saw in basically the live surgery. So let's talk a little bit about segment preparation. There's different options, self-cut, pre-cut. I use basically pre-cut tissue that comes from the United States. I use electron beam tissue, which is basically one of the options. Initially, the description for basically using a segment preparation was done by Susan Jacobs. She made this basically chafine, where you simply cut out the ring segments, got a double chafine basically on the surface itself, and that's how she basically made the segments. Of course, you don't need to use you need to use clinical grade tissue, but not basically good endothelial cell count, and you can use basically the chafine to do the tissue preparation. Once you prepare your tissue, you then basically, she now uses basically a manual technique to basically thread in the segments into basically those holes that have been created either with basically a laser system. Chadi has basically developed this care mold, which basically has a heater on the surface itself, and it makes the whole thing a little bit more stiffer, so it basically behaves like a PMA segment. I don't actually dry them. I just leave the E-beam segment out of the container for a couple of minutes, and by the time I've cut the tissue with the laser and gone back to the patient, I do this in a refractive suite now. It's so quick to basically do the surgery. Actually, the segment has dried up, and then I just basically put it into the incision. It basically will go in quite easily as well. This is just Shadi's basically marker. It's like a heat. It's like a heat thermal. That video didn't work there. Okay, it's basically a heat thermal marker. You basically put it onto the surface. It basically will make it a bit more stiffer to help you aid with basically the insertion. Okay, let's look about basically femto basically preparation. So this can be done with basically several laser systems. Bida, we're basically the first one to use the Zima for this. David Gunn in Australia had basically used the Alcon system, and now he's basically gone to the Zima system, and Alcon basically also did the same thing itself. But the problem with this, when they started basically using this, is that they were using a basically lamellar keratoplasty module in order to just cut that segment. Okay, and I did do this in Singapore, but I can tell you the patient was covered by insurance, was not being recorded, right? So she didn't basically pay anything, but we basically was charged the same price as a lamellar keratoplasty just to get those segments. So I thought this is ridiculous, right? So I just use those segments itself. So it's very cumbersome to basically use that. Alan basically published this paper in March 2020 showing the feasibility of using it itself, but it's basically a very tedious and customized approach to basically using this, and you're just using that tissue. The rest of the tissue is going to waste itself. So clearly, you know, we had to basically come up with something better. And of course, it was only producing symmetrical segmentation for using a keratoplasty module to cut basically the tissue as well. So Zima came up with this idea about basically using a system. Oh, the video's on. basically using a system where you can use a femtosecond laser, and this basically allows you not to just cut a basically symmetrical system, you can cut an asymmetric segment using this new module on the system itself. And you can see this basically cut on the donor tissue. This is their artificial anterior chamber maintainer, and in fact you can cut two, you can actually cut about 4 or 5 segments just from basically one normal donor corneal tissue. Of course, if you do cut multiple segments, this has to be done basically in the eye bank and then tracked from the eye bank out to basically surgeon. Essentially, this is how it basically cuts on the surface. And it's completely customizable, so you can customize a thick end, a thin end. Here you can see a difference of basically 550 microns on one side up to basically 750 microns basically on the other side itself. So you can basically go back, look at your tomography pattern from your patient to give you an idea basically of how to basically cut the segment itself. And back in 2023, he published the first publication showing you the outcomes of these asymmetric or femtosecond laser basically segments as well. And I'll show you some basically data to show you how this basically works. And this was followed up with another paper looking at 1-year results, again using femtosecond laser cut tissue and basically femtosecond laser preparation for the incision as well. And this just gives you an example of what you can do with these asymmetric segments. So here you have the tall cornea. It's important when you're basically assessing where you put your segments, you take a tangential map from basically the corneal tomography. You shouldn't use axial or basically sagittal maps because this averages everything out. The tangential map will tell you where, actually you should use a Gaussian map, but most machines don't have that available. But if you don't have Gaussian available, tangential basically is the next option. You can see here, ideally you want basically an asymmetric segment. This is what the laser can basically be programmed to cut. So you can see 500 microns at the top, 750 basically down the bottom. And then you can see over here, this is basically what it looks into the eye. And of course, the thicker the tissue, the variation you're going to get in basically the compression around that area. So you see the 500 microns has gone down to 261, and from the 750 has gone down to basically 423 on the right-hand side, where you'll have a different compression effect as basically the tunnel is cut. Likewise, you can see from pre-op to basically the post-op effect, you can see an 48.57 down to basically almost a 40 micron basically a decrease in the cornea. And again, another case basically here, the left eye pre-op, again down to basically post-op, about 48.96 down to basically 41.7 itself. So the software now has been basically officially released, so this is basically clinically available. You can see at the top, you can basically cut different number of segments. If you're cutting from the donor cornea, obviously as a surgeon, you can only cut basically 2 if you're basically going to one patient. But if your eye bank is basically going to cut, and you can put the machine in the eye bank because it is portable, then they can cut about 4 or 5 basically segments from basically one cornea. You can adjust the optical zone. Of course, this will give you an idea of how many basically segments you can cut. The arc length obviously is basically tunable as well. And you can then basically look at shapes, so obviously symmetrical, tapered, and you can have double tapered. So this allows you to have customization on the patient's corneal tomography that you've taken from the tangential map basically beforehand. You can feed this basically to the eye bank, so we have a form you just basically fill in, tell the eye bank guys this is what you want to basically cut, and then they'll basically cut the tissue basically for you as well. And likewise, you can basically then censor the width of the segment and the thickness that you want basically over here as well. This just shows you basically a real-time optimization where you're basically doing the cutting. So he's cutting basically under the laser system. Generally, I'll cut, when I do, I cut basically the pockets on the same time, and then basically cut basically the segments out. All the segments have been cut by the eye bank, and they basically get sent down to us in the refractive suite. So this is the AC maintainer. You can simply just peel off from the surface there itself. Some people will mark the Bowman's side when they're basically doing the feeding to help with the orientation. I mean, I've stopped doing that now because actually you can actually quite see it quite well with the E-beam basically tissue as well. And you can see it's quite easy basically to feed in, but I like the fact that you can customize it with the laser with this asymmetric segments because you can't do that basically with the standardized technique itself, where it's a bit more difficult to basically do that. Okay. So these are the preparation techniques. So like I said, basically surgeon prepared, as I showed you basically with new customized software, the femto, or pre-cut. If you're starting off doing CARES, personally I would just take pre-cut tissue. I get it from the basically Lions Eye Bank in the United States. If you start also basically do it, it's quite cheap. It comes in BSA, you can keep it on shelf life storage for a year, and then basically take it out and you can have it, you can tell them what size thickness you want. You can't customize it like you can as well with a laser, but I think if you're starting off, I think it's a great way of doing it. Of course, if you need a laser to basically do the tunnels, but 3 or 4 femtosecond lasers can all basically do the tunnels. One thing I will say with the SEMA system, because it has an inbuilt intraoperative OCT, if you're doing ectasia cases, I think it's quite useful. I did a lady who had ectasia after LASIK, and I could see the flap on the OCT, so when I made the tunnel, I could see exactly where to put basically the segment. So it gave me a bit more reassurance that my basically tunnel was well underneath that LASIK flap. So I think that has an advantage itself from there itself. So Pre-cut, irradiated basically tissue. So the femtocut tissue in the US, basically from CTAC or lines, are all performed basically with the Zima system. It's just a different software that Corneagen basically have compared to Lions Vision. Lions Vision has a new upgrade, basically software with the asymmetric system, and they're going now to basically doing fresh tissue, and now basically e-beam tissue will also be available to basically femtocut. Currently the one I'm using, which is irradiated, is not basically femtocut, it's basically standard. Okay, a little bit on nomograms, so this will be quite quick. Obviously, there are different nomograms depending on what tissue thicknesses you saw. As you saw Brandon's basically video, that tissue was super thick, okay? So your width of your tunnel is going to basically be wider. Because I'm using E-beam, I basically use the same nomogram that Shadi basically uses on his publication. David Gunn in Australia has a very nice nomogram where you plug in all the data and it will tell you what kind of segment basically symmetry that you're going to use. If you're going to use fresh tissue, I would use Susan's nomogram. If you're going to use Cariclear, I would use basically Eileen's basically nomogram. So it really depends on what tissue you're going to do, because it's going to affect the size of your tunnel when you're putting that basically segment in as well. The last bit, I'm going to show you just a few basically results from over here. So this is from Shadi's basically publication looking at evaluation of basic tomography outcomes. So generally most of the segment sizes are 750 or basically 500, and when you go through a depth, you can see from here from 250 basically up to 300 in the centration. You know, you can basically move it with a laser system after the docking. You can see basically 81% improvement in corrected visual acuity, in 2 lines basically improvement as well. Likewise in unaided distance visual acuity, but the idea is to basically regularize the corneal surface. But interestingly, obviously, what I think you look at is a reduction in keratometry. Generally, I don't do higher than about 62, 63, and you do get this kind of effect where you get about 6 or 7 diopter basically effect in reduction over time. There is some basically change, obviously, in the K-max. You can see on the sagittal, this is basically K-mean reduction as well. And obviously a big reduction in the aberration, especially obviously the vertical coma is going down as well. Now when you study the epithelium, there will be some epithelial remodeling over the area of the segment and over the area where the segment is not as well. So it's important to basically look at the differences. If you chart this basically over the area and you look at basically stromal elevation divided by basically epithelial thickening, you'll see there is a thickening and remodeling over the area of basically where the segment is, and a slight depression in basically the stromal elevation. This is normally stabilized basically by one month. So there is some variation itself. You're going to combine this, say later on, say with a cataract procedure or some other refractive procedure. I would wait until you get stabilization, because it's between 1 and basically 3 months before you basically plan any surgery itself. So he's published recently the 1-year results basically using this system with these the care segments that have been laser cut using basically the graft preparation. So it's published in Cornea in March last year. And similarly, Alan Zayed basically using a different laser system also basically published their data as well, showing very quite comparative results as well. Okay, so a few things on this is my last slide now on complications. Obviously, it's important to basically talk about this. You can get roof tears of the tunnel. It's rare, basically, incidents as well. I mean, a lot of this is related to the fact of the depth that you basically put them in itself. Roof melts have basically been described. A lot of this is related to compression of the segment if they're slightly basically thicker itself. There are a couple of cases of rejection reported in the literature. Often these are in atopics or irobics, so you do need to be careful, and you do need to treat the allergy and the ocular surface complications as well. These are basically described in these 2 case reports over here itself. So femtocare is basically development, and basically it's an evolution from trepanation to basically femtocutting, and now to really customization. The early results are actually quite promising, and of course with the new software release, I think this is quite an interesting development. The next challenge will be really refine the nomograms to improve our outcomes. Thank you for your attention.
In the 15 minutes that we have left, I'd like us to go through 2 cases. And that will give us also an opportunity to ask you some questions about your experience. But if I understand correctly, the main difference with your approach is that you can customize the segments, taper them, compared to what we just saw.
Yeah, with laser, yeah.
And go back to your insurance questions, because no one is recording.
Yeah.
Is this considered a transplant, whereas the other would be like
So we charge, yeah, so that's a good point. So we charge so it's just charged as basically as a segment. So we pay, the patient pays a segment, so there's a laser fee to obviously make the pocket and stuff, but I don't even do this in the main OR, I do it in our refractive suite because it's got HEPA filter and everything from there itself. And the surgery is basically so fast. So we basically classify it as a special transplant. But they don't have, but because I'm using electron beam tissue, it's already been basically completely irradiated. So we do blood tests for the patients pre-op, but they don't have to pay transplant fee itself. They're just basically paying we charge for the laser charge itself, and then basically that's it. Yeah, so it's much, much cheaper. And that's why initially, I did a couple of cases of prestige, but I moved away from that because sending Singapore was too expensive to do that. It wasn't viable. And then when I asked people why they were able to do it in certain countries, they said to me the tissue was cheap, but that's why. So that's why I moved away from that. And I like the segments. It's very simple to do.
Could you put the next presentation on mic, please, so that we can go through the cases? You had a question?
Okay, that's great. Yeah, John or anyone in the panel, obviously this is very exciting technology. The question is, will it be long-lived?
Yeah.
So I think when we last talked, you said your experience is now 3 years, is it?
Yeah, with CARES, yeah.
Yeah, with CARES. So the question is, have you seen regression over time? And is your gut feeling that this compares to PMMA implants? Or is there an advantage one or the other? That's a long answer, I know, but short answer.
So the short answer is that, there is some change in that early time. Initially I was a bit skeptical. I thought, will you get melting? Because you're going to get, it's allogeneic where it's tissue. Will you get release, and will the tissue basically melt? And that's why when I saw the appeal of E-beam, to me it looked quite attractive as an option to basically go on for that itself, because E-beam definitely will not melt, but it's actually much more robust tissue. So that's why I thought, okay, this is a good way forward. So I haven't seen that. I've seen other data that's longer term than we've basically been using, and it seems to be quite robust from there itself. There is some change. You do get some basically shrinkage from there itself, but there are cases that Susan and Jess were also mentioning where they've taken them out for certain reasons years down the line, and you can actually basically slip it out from there. With respect to the question about comparison with ICRS rings, Shadi did do a paper where he did quite a decent job of trying to compare, and certainly in the region from what they were comparing, even from his own data, I think it's important that the same surgeon compares their own data results. It's very different. There's so much variation in literature from ring segment stuff like that. The same surgeon, same sitting, he was getting comparative results with what he was getting with his rings, and in certain situations he was able to take out ring segments with a complication, repair it, and replace it with a care segment. So that to me was quite an appeal basically from that. Having said that, there's still parts of the world, like I was in China a few weeks ago, they said to me, we're talking about something about care, they're saying forget about it, we don't even have any idea to basically link tissues. So they want something else, and I think there's we had some discussions about what else will come in the future that we could basically maybe even replace that on. But, so there is still parts of the world where this is never going to happen.
We'll go further with the case, thank you. I think it is very exciting, and we will also come back in the cases. So the first patient is a 31-year-old male, has keratoconus in both eyes, diagnosed in 2021, is not known with allergy or eye rubbing. You see here the tomography of the right eye is stable, and the left eye has shown mild progression from 2021. He is unwilling to wear contact lenses and is looking for an option to improve vision in the left eye. What would you do? Which one of these options, or would you do something else? The case is a courtesy of Dr. Fogler, so any of the other panelists, what would you do with such a patient?
Okay, well, first of all, first of all, you have to be sure that it's a stable keratoconus, right? In the case you are not sure about it, of course you can go first to cross-linking. But I will do in this case, because the patient is 20-30, I will like to see how are the aberrations first. But I will go to customize PRK, trans-PRK, in order to improve the aberrations. Because it's 20-30, I think it's a mild keratoconus. It's a good option for that. Of course, you have to be sure that it's stable keratoconus.
So you would do first cross-linking if he's not stable, and then PRK, right?
Trans-PRK, cornea guided.
Okay.
That's little.
And how long would you wait between cross-linking and the PRK?
Depends. If it's epi-on cross-linking, you can do maybe 1 month later. It's epi-off. You can at least wait 3 to 6 months, because you can have also another factor that could be the flattening effect of the epi-off. That's why we wait a little longer.
Yeah, we have a good number of patients treated with follow-up of 2 years on the first, 5 years on the first 30 patients, and then 2 years on the next 30 patients. Doing same-day cross-linking and cornea away from guided PRK. We aim for a little bit of soft correction, so 20-30%. And this is a mild refraction. He should be doing fine with cross-linking and same-day PRK. wavefront guided. That would be my approach.
So you do it on the same day?
So having said that, with that vision and the other eye, probably I would tuck the patient out of surgery. But if he is insistent and he is really looking forward to a surgeon that would be providing good vision, spectacle free, then I would go for corneal reference guided, same day cross-linking.
Great. So, Dr. Vogel, that's your case.
Yeah.
You chose to do an intracorneal rig segment. Would you like to share with us what were your...
Yeah, my own personal experience of doing combined PRK with cross-linking in the short term has been good, but it can be unpredictable in certain cases that can end up with progressive flattening, like an overcorrection, and then once that happens, it's very difficult to reverse that. Then you have to ask the patient to wear rigid contact lenses. This patient has adequate thickness, and the keratoconus is mild, and based on my own experience, I know that if we put a ring, it's a reversible treatment. If he's not happy, I can undo it. But if I do a PRK with cross-linking and he's not happy, then again, so
reversibility was important for you.
Reversibility was important, and I was fairly confident looking at the topography based on my own past experience that with the ring we would be able to meet up with his requirement.
Would you have considered this patient today for cares, or would you still go for...
We could have done with cares, but like I said, that I reserve cares where I need more customization. If it's a fairly straightforward case, I think still a PMM ring is reasonably easy, and it even cosmetically looks quite good.
Okay. Any questions from the audience about this case? If not, we can...
I would concur with Raj. Being 31-year-old and with a mild keratoconus, I think the risk of progression is quite low, even untouched, and it's going to be almost zero with an implant. So I would start with an implant. I think one of the beauties of the classic implants is the reversibility, but also adjustability. I don't know how frequent is adjustment with cares. Can you really change the position? It's done often?
You can, but I think the overall manipulation would be greater because this is a PMMA segment, has a positioning hole. You can really move it much better compared to a care segment.
Which nomogram do you use?
Well, this is there is no direct nomogram, but it's based on the keratometry, the astigmatism, and what is the sphere component. So if you're treating purely astigmatism, you go for a smaller arc. But if you want to treat the spherical component as well, then you can choose larger segment or asymmetric ring. So I think it's multiple factors that we take into place.
Okay. We'll move to the next case. I think this was the result.
And that's the post-operative wavefront comparison. You can see pre-op and post-op, you can see there is a significant reduction, and that shows you, if you look in cross-section, it looks the same as what you see with cares. You see the segment is at the right depth, you see the epithelial thickening just central to the segment that's been placed. So,
do you think that the part of the effect that we see with cares is because we can implant them more superficially?
yeah, but I think my personal experience, I started off with 200 microns. Now I'm comfortable putting them at 300, 330 because you see the overlying stroma getting compressed quite a bit, and in the long run, I'm worried about any extrusion.
That's a very important point, I think. I don't know if we are aware that whatever we implant very superficial in the cornea or deep can change totally, can be just the opposite effect. Anything which is superficial will have kind of lamellar effect depending on the thickness change. Anything which is deep does not have a lamellar effect, has only a biomechanical effect. I don't know, because some of the data on, for example, in the case of cares, some of them are implanted at 200 microns, which is relatively superficial. But if you implant it at 400 or 300, then they should have the same biomechanical effect by the space of the patient, like with the inner rings. But it's not very clear because some surgeons use a different depth.
I agree with you. This is why it's what John said, is comparing apples and pears. It's very difficult to compare the effects because amongst other, the thickness where you put it is very different. It brings me to the second case. This is a male, 57 years old, with pellucid marginal degeneration, and in the right eye, you see here the refraction and the vision, quite significant astigmatism. But looking at this topography, it looks quite regular, relatively regular for this amount of astigmatism. The patient is contact lens intolerant, spectacle intolerant, of course, because of this amount of astigmatism, and wants to improve the vision in the right eye. What would you do in this patient?
First, you have to see again the aberration. So, first, you have to do the therapeutic part, and then the refractive part. So, for example, in your cases, this patient have a high order aberration, especially, positive horizontal coma. I would try to do first, stable like that, maybe a ring, and then maybe a toric eye cell, because I think it's the only thing that you can do with -11. If you have good anterior chamber, you can do that.
Yeah, that's what I just looked again, how old the patient is. Because, would you do a 57? Would you do an ICL?
Yeah, well, no, but you can go with a toric pseudophakic.
Can I make a comment about this concept of contact lens intolerant? I mean, you're presenting the case, and it's taken as obvious the patient is contact lens intolerant, because the patient really does not want to wear a contact lens. These are not the same things, right? And many patients will say, I can't stand a contact lens. That's not the same as contact lens intolerant. And I think it's important to explain to these patients that there's nothing we can do for them, almost nothing, that will give them the same vision that they're going to get from a scleral lens. And they need to wrap their head around it. And even if we beg them to try the scleral lens, and if you really don't like your 2015 vision out of it, we can consider to put you through a series of procedures, which will take time and cost, but they will improve your uncorrected vision. The attraction of CARES is that almost all the patients, barring complications, will have much improved unaided vision on day one, and that's why there's a lot of excitement. But I think we need to be a little bit cautious about accepting the term contact lens intolerant.
I completely agree with that. For patients who need a procedure, I still do a contact lens trial for these patients because I need to know how much is the vision going to improve. And sometimes when I send the patients for contact lens trial, they come back and say, oh, I don't need the procedure. I can see very well, because they haven't tried contact lenses. They just have the perception that, oh, I will not be able to manage with the contact lens. And I always tell them that no matter what procedure I'm going to do, it will never match the quality of vision that you're seeing with the contact lens.
Well, I think we all agree about this. I think what we need to be careful of, that there will be also a financial motive to do something else from the side of the physician, not only from the side of the patient.
No.
That could be the case. And I expect it will only increase in the coming years.
In this case, also the astigmatism, although it's high, it's still fairly regular, and 20/30. So we have IOL manufacturers in India, so we sometimes make customized toric lens.
Yeah.
We tell them we need it for 11 diopters. They customize the lens and give it to us, and you do a cataract surgery, implant that lens, and your patient is unaided 20/30.
I agree. With this patient being 57, probably that would have been, I would have said, let's wait a few years. When you'll get some cataract, then we'll consider a cataract surgery with a custom-made toric IOLs. However, here, topo-guided PTK combined with cross-linking was performed, and with quite a good outcome. If I can switch to it, yeah.
Sorry.
Yeah.
In-home test is also a simple way to know how the patient can improve vision.
Yeah, of course, or a contact
Can you
lens
repeat the
trial.
question?
A contact lens trial. That's how I usually try to convince the patient to say, okay, you don't want a contact lens, but for me, it's really important to know what you could see with a contact lens. So you have to go through it, and then we have something concrete to discuss, because it's not perception or it's not good or whatever not. Then you can put really the outcome with a contact lens compared to the outcome without a contact lens. So this is the unaided visual acuity in the right eye, 610, and this is the corneal topography. And this is the case of Caterina. She's not here now, but I'm curious to know what her results in terms of regression in the long term with these kind of high therapies are. That would be something that I'd be concerned about. I'd like to skip to another case, and we go back to the other ones if we have time, because we don't have a lot of time yet, and I'm curious because this is my case. To be honest, and I promised her that I'll discuss it today, so I can't come back home with empty hands. And this is about, we've talked about reshaping, and we've talked about arresting progression, but we still have a considerable amount of patients that have tissue loss, or that have hydrops, or that have corneal scars, where keratoplasty in some kind of form is still needed. So this is a 51-year-old lady. She has pellucid margin degeneration in both eyes. In the left eye, she underwent cross-linking in 2021. She had a hydrops in 2023. Just to be clear, she's been my patient since this year. And in the right eye, she's had a hydrops, and this is when she came to me. And I put in the right eye SF6 20% intracameral gas tamponade. You still see the suture on the right eye because this was taken a week after. It had helped to reduce the edema considerably. And I chose not to put sutures considering what would be the follow-up therapy. She has eczema, she has hay fever, she has asthma, so the full inflammatory package. And her vision actually is, with glass correction, is quite good. And the right eye is 0.5 with pinhole, you asked, 0.8 minus, and then the left eye, 0.9 minus. So I was wondering, this is an OCT images of the right and left eye, and these are topographies, but I don't think that they contribute a lot more than what we've seen so far. What would you do in such a case? Would you consider a combined gas tamponade with or without tension sutures, a penetrating keratoplasty, a crescentic anterior lamellar keratoplasty, adult? If so, what are your tips and tricks how to do that? Or manage it conservatively, considering that she has quite good vision?
But the hydro was very peripheral.
Yes.
Okay.
Did you make her happy at this point? And why is she searching for another answer?
She's concerned if she can use her contact lenses, yes or no. She's concerned what would happen if she'll have a third hydrops, and it will be centrally. So if we are doing something now, maybe we can help prevent a worse outcome later. So these are the questions that are keeping her busy.
Well, I tell her, one, to stop rubbing her eyes, because that's clearly what she's doing. Two, because I guarantee if you take her tears and check her MP9, it's going to be elevated, even though her eyes are wide. I treat her with cyclosporine, reduce the inflammation on the ocular surface, because she's definitely got, you have these kind of episodes of high drops in the eyes up. I would not touch with large bulk surgery at this moment at all, basically, because it's peripheral high drops. I would treat her with cyclosporine topically, check her MMP9 levels, reduce the ocular surface inflammation, and put her with a contact lens if you want something. Because I think that she's...
I refer her to a dermatologist because we use also a lot of biologicals in these patients. So that's what I said, we'll do that first, but I was wondering, once the eye is, once the inflammation subsides, the eczema subsides, would you consider surgery in such a way?
No, I personally wouldn't. She's
given the good vision you want.
Yeah, she's got good vision. If she wants to see better, but I put it.
And if she comes in after a year, she has a high drop centrally, and then
tell her she hasn't been taking her drops, right? No. There has to be a mechanism. If you think about it from the pathological side, there has to be a pathological mechanism going on here for her to develop the high drops. What is going on, and you basically mentioned in the history. And definitely with all the biologics that are available now, and even starting on with topical inflammatory agents, I would start with that and would tackle early to basically reduce that.
Another thing, this is a very aggressive PMD. There are also another corneal findings that you can see that it appears a new lines but horizontal way now, okay, against that above lines, because now it's at the periphery. Another thing is that that's going to induce this peripheral edema. What it's going to make is a flattening on the center of the cornea. So this patient is going to improve a little the vision, okay? So you have to take care of also that, because sometimes you want to correct something that maybe you don't need to correct.
And would you use scleral lenses on this eye?
Yeah, this time you want to try that, but I think it's because it's not peripheral. I think you define with a gas, perfect, and I will wait, and what you're going to see the vision, which because sometimes the scar is going to make like also like intracorneal ring at the periphery. So wait.
But I think Dr. Dickman is asking, is there a surgical prophylactic procedure in someone who has already had one, well, decimate tear?
Well,
Is that what we're asking?
You mean to prevent, going back, well, I mean, this basically was, saying that, to get true high drops, you need a break in the pre-decimate level and basically decimate. It's not just pre-decimate. You have decimate break, you don't necessarily get high drops. We know that clinically. So you need a break in both things. But, from a treatment, there's not, if you're gonna, I've seen high drops occur in PKs before, in patients who have long-standing grafts. I've seen, we published this when I was a resident in 2005 in Moorfields. Somebody walked in with high drops in an old PK that was done in a keratochronic patient. So you can see that basically from happening. Again, with a bit of an atopic and eye rubber itself. So I don't think any graft surgery per se will see you. And if you have long-term dogs, right, you will see if they're long enough, you will see some basically, you can see recurrence of basically keratoconus, but it's rare because obviously the keratitis takes a long time to basically migrate.
Yeah, we've seen high drops even after PKs and after dog.
Yeah.
So I wouldn't do a procedure to prevent high drops. Yeah. Even though she has good vision, good correct vision. So I'll do a very conservative management, have the ocular surface well treated, and if she needs a scleral lenses or rigid contact lens.